I am the Dean of Research at the Indian Institute of Public Health, and a very warm welcome to all of you, those who have come from within Hyderabad, outside Hyderabad and outside India. We welcome you warmly to the Symposium on One Planet, One Health and One Future, which is hosted by the Cyrus Poonawalla Center for Infectious Diseases and Pandemic Preparedness at the Indian Institute of Public Health, Hyderabad, in collaboration with the Oklahoma State University, USA. It is a pleasure to see so many of you here today, united by a shared commitment to exploring and addressing the critical intersections of human, animal, and environmental health. I first of all welcome everyone, especially the guests of honor and the distinguished guests here, for the traditional lighting of the lamp. Welcome you to the stage, please.
I come to the first.
Traditional lighting of the lamp, please. Dr. Nandu. To kindly give the inaugural address. And I will introduce Dr. G. Narendra Kumar, IAS, AG MUT 1989, has assumed charge as Director General of National Institute of Rural Development and Panchayati Raj at Rajendra Nagar, Hyderabad on 27 January 2021 for a period of 5 years. Earlier, he was the Additional Chief Secretary, Government of Delhi. Dr. Narendra Kumar Ji, IAS, possesses a PhD from Osmania University and holds a master's degree in public administration from the Maxwell School of Public Affairs, USA, and a certificate course in the Information System Management from Syracuse University in the US. He was instrumental in setting up of 4 universities in Delhi, as well as in increasing access to quality technical and higher education in Delhi. Dr. Narendra Kumar Ji is also known for developing Pondicherry as the hardware capital of India. He was also the IT Secretary in Government of India. Earlier, he also worked in various national and international academic institutions such as ASCI, which is the Administrative Staff College of India, as well as ICRISAT, besides his wide range of administrative experience in environmental protection, social and sustainable development. So I kindly invite our guest of honor, Shri G. Dr. Narendra Kumar, IAS, Director General, NIR, DPR, to the stage to give the inaugural address. And I request
Distinguished delegates and esteemed participants, it's my great pleasure to participate in the symposium on One Health. I've been given 5 minutes to speak on this, so I've come prepared only with 5 points that I will make, 5 short points. On One Health, importance of One Health, all of you know better than I would know. One Health, as you all know, has become prominent with the pandemic, with COVID. It's been there around, as all of us know, but it has really come into prominence with the COVID, and therefore we need to leverage on that to take forward the One Health agenda for the betterment of humanity. And when we look at it from the context of COVID, the first point that I wanted to make is that we need to understand such epidemics and pandemics as to how they really emerge and develop a meta-synthetic framework on what really causes these epidemics and pandemics, and both at a human intervention level, its spread and its control, and see how we can better control the epidemics and pandemics, develop a framework for it, systematic framework that can be taken forward to the community by being able to better control it. Other important thing that I wanted to say is, as we all know, the importance of One Health really to the entire community has come about because of COVID. A lot of changes have happened because of COVID. The way patients are now being treated, the community mobilization, the way we work, there have been significant changes after COVID. So we need to understand and learn from various experiences in tackling COVID all over the world. And from this, we have to draw lessons there can be for One Health in a holistic manner. So that's the point I wanted to make today. Another key aspect that I wanted to share with you, especially from an Indian perspective, that I am the Director of the National Institute of Rural Development and Panchayati Raj, which acts as a think tank for the Government of India Ministry of Rural Development and Panchayati Raj. Thereby we mean to say that we give them ideas on how ongoing rural development programs, for which there is an investment of 2 lakh crore rupees made by the government, which is substantial amount of money. How can we improve these programs? Working with the community is a substantial part of our work and substantial part of work of the government. So one key aspect that happened during the previous COVID in India was that initially COVID in India happened as an urban phenomenon, mostly to the cities, Delhi and so on and so forth, from where it spread to the rural areas in the first wave of COVID. There was a second wave of COVID. In the second wave of COVID, we saw the converse, the COVID spreading from the rural areas into the urban areas very substantially. Which goes to show that, look, when the first wave of COVID happened, a lot of people moved away from urban areas, they went to rural areas. Perhaps the virus got incubated in the rural areas, and subsequently the second wave of COVID really came from the rural areas into urban areas. Therefore, one cannot neglect urban area or rural area from a healthcare perspective. When we talk about public health, both are equally important, and we need to realize the importance of both urban areas and rural areas. Urban areas cannot be immune to what diseases can spread from rural areas, and we have to find ways of tackling the diseases in the rural areas. And when we talk about One Health, one important mechanism is constant surveillance to understand that what new diseases are emerging, which have potential to become epidemics, which have transboundary kind of spread, and as we all know, looking at the vaccines, diagnostics and therapeutics. So beyond that framework, we need to look at the community surveillance. Surveillance cannot only be left to the medical fraternity, but it has to go down to the community. Community as triggers, as pointers to say that, look, this kind of disease, this kind of abnormality is coming up, these kind of zoonotic diseases are coming up, and they need to be attended to, they need to be tackled. So if we train the community to be able to do that effectively, our surveillance burden will substantially come down. That's something that we need to work on, along with training the community to perform the surveillance function, inform the medical functionaries on what is emerging and what is coming up. We also need to train them on coping with such kind of epidemics and pandemics. So how do we do this? And we in the National Institute of Rural Development have been looking forward to do that from several years. We've had a village disaster management plan exercise, which we developed, the framework of which we developed with the National Institute of Disaster Management. So, but unfortunately, that disaster management planning exercise really did not go to the community, did not go to the villages. If it had gone to the villages, if we've been able to develop well-trained volunteers in the villages, I think the impact of COVID would be much less. Productivity loss would have been much less. And that's what we're trying to do, to now take forward this village disaster management planning framework, taking also into consideration various pandemics and seeing how we can develop community volunteers who can develop effective plans to be able to control the pandemics or the epidemics at the village level by themselves. Well, what happens in many of these situations, not only we have pandemic, but also any major disaster, supposing there is a big fire accident or there is an earthquake, there's a lot of time that is required for the external forces, external resources to go and reach that village to provide them support. By that time, I think a lot of damage is already done. So best is to prepare the community to be able to deal with any disaster, including a pandemic and an epidemic. So they become the first responders. People talk about first responders being the police force or a trained first responder, a disaster management force coming. But a lot of time is taken in communicating the message to the first responders, to the trained responders, to go to the village and actually help the villages. So an effective way is to train the community in preparing village disaster plans and effectively implementing them. using the volunteerism in the villages. And that's what we are headed towards, and we look to support from various experts who gather here, various participants, and reinforcing the village disaster planning framework to incorporate epidemics and pandemics in it, and train the villages substantially on how to prepare village disaster plans and to implement them. Another key initiative that we are dealing with in the National Institute of Rural Development, along with the Ministry of Panchayati Raj, is something called the localization of sustainable development goals. Sustainable development goals, as many of us will be aware, are targeted goals to be achieved by 2030. But they are sort of diffused in the sense that they talk about broad global targets to achieve the poverty-free village and so on and so forth, a hunger-free world, like that. But coming down to the local community, what does it translate into? There's no clarity. So I think India is one of the few countries which has come up with local action to achieve sustainable development goals. How can each panchayat be asked to prepare a plan to achieve the sustainable development goals, such as achieving a poverty-free village, achieving a healthy village, a socially secure village? And when we talk about the localization sustainable development goals, one of the important themes out of the 9 themes evolved by the Ministry of Panchayati Raj for all panchayats in the country is a healthy village. And here we expect the local sarpanchas and the panchayat leaders to provide leadership in moving forward with the agenda towards the localization sustainable development goals. But the parity here is that the panchayat leaders either illiterate or semi-literate kind of people, expecting them to take up various initiatives, achieve goals which are monitorable, achieve results which are monitorable, that becomes a challenge. Unless we give them a clear-cut framework in moving towards healthy village, supposing you want to reduce the infant mortality rate, what is a package of practice, what are the various things you can do to reduce infant mortality rate in general. And of course, they can customize whatever package we give them to suit their local requirements. So there is need for clarity in developing such packages in moving towards the localized sustainable development goals, especially achieving the healthy village theme. So that the healthy village theme obviously should include One Health issues such as the animal-borne diseases, transboundary diseases, and so on and so forth. And we look forward to that also being incorporated in the healthy village theme work that we are undertaking. So these are a few points that I wanted to make to urge you to do more research on how epidemics can be better controlled, especially drawing upon our COVID experiences. How can we involve the community in surveillance towards One Health and move towards preparing village disaster plans, and also strengthen the sustainable development goals at the local level. So these are the few things that I wanted to place before you, and I hope that the symposium will be immensely successful and show us a new direction to take to be able to move forward in the manner intended to achieve One Health for the entire community. And I'm very happy that the IIPH has come forward to organize this symposium. I'm also gladdened to see a number of veterinarians participate in the symposium, because this is unique. Normally we think in silos, even in the among the medical fraternity. So we're looking beyond those silos, bringing in a lot of veterinarians and other practitioners. And I'm very sure that with all these diverse range of participants participating in this symposium, this will be very successful and show us a new path for progress. Thank you very much.
Thank you, sir, for that excellent inaugural address, stressing on the importance of One Health, especially after the COVID pandemic, and also suggesting ways for building resilience, especially at the community level, the village level, etc. And we know that, we are all gathered here, and many of us know that One Health is a holistic approach. It emphasizes the interdependence of all life on this planet, which is humans, animals, and the ecosystems that we all share. This interconnectedness impacts our health, our communities, and our world. And according to the WHO, we know that One Health is essential to designing as well as implementing policies, programs, and research that allows various sectors to collaborate and communicate, ultimately leading to better public health outcomes as well as health outcomes. The goal of the symposium is to foster meaningful discussions, share cutting-edge research and insights, and collectively develop innovative strategies that leverage the One Health approach. We are all excited to have very meaningful discussions today, share the work that we have been involved in, also share the challenges that we face with each other in today's event. Over the next few hours, we will hear from the chairs, the panelists, and the participants who will all be sharing their views, their research as well as insights. So we really encourage conversations among each other as well as among institutions as part of this and following this particular symposium. We are deeply grateful to everyone involved in making this event possible, especially the Cyrus Poonawalla Center for Infectious Diseases, which is based at IIPH Hyderabad, and our esteemed partners from the Oklahoma State University, USA. This collaboration underscores our commitment to global partnerships that bring diverse expertise and experience and perspectives to the forefront. So a quick agenda for today's program. As you all have a copy of the agenda, I would like to re-emphasize that throughout the day, we will hear from prominent speakers and participate in interactive sessions focused on various facets of One Health. We encourage each of you to speak, engage, ask questions, especially the students and the scholars who have come from outside also. And please exchange ideas that could spark new collaborations and actionable solutions going forward. After the break, we will start the panel discussions where we will discuss the various topics that are there in the symposium for each panel. We invite all of you and all the stakeholders to stay and contribute to the discussions, please. Now, without further ado, let me introduce Professor Jerry Malayar, who is Senior Associate Dean for Research and Graduate Education at the Oklahoma State University, USA, who will be formally welcoming us all to today's symposium with a keynote address. It's my honor to introduce Professor Malayar, who is the Senior Associate Dean for Research and Graduate Education in the College of Veterinary Medicine at OSU, where he also holds the position of Professor and McCaslin Chair in the Department of Physiological Sciences. He has over 25 years of experience in academic veterinary medicine, including 20 years of experience in administration of multidisciplinary research and training programs. By appointment of the Governor of State of Oklahoma, Professor Malayar is also on the Oklahoma Science and Innovation Council and the Health Research Committee of the Oklahoma Center for the Advancement of Science and Technology. This is, by the way, a state agency for which the committee plays an advisory role. For 11 years until October 2021, he served as State Director for Oklahoma EPSCoR/IDEA and was a member and Vice Chair of the National EPSCoR IDEA Coalition Board of Directors, which is an organization representing 27 member states. Professor Malayar was the past chair of the Research Committee of the Association of American Veterinary Medical Colleges, a founding member of the Scientific Steering Committee for the Oklahoma Center for Adult Stem Cell Research, which is a program of the Oklahoma Tobacco Settlement Endowment Trust. He is also a member of the advisory board of the Oklahoma Center for Respiratory and Infectious Diseases at OSU, a member of the advisory board, Oklahoma Nathan Shock Center on Aging at the Oklahoma University Health Sciences Center. He works with veterinary students, postgraduates, and faculty every day, and has been principal advisor for a dozen PhD graduates and served on advisory committees for dozens more across multiple departments and disciplines. Professor Malair has authored more than 70 peer-reviewed publications of original research. I welcome you, sir, and I request Dr. Rajan Shukla to present him the plaque.
Thank you for that kind introduction. It's a great pleasure to be here. Three of my colleagues from Oklahoma State University are here with me as well. We're having a wonderful visit to Hyderabad. So we're very pleased to be here and very pleased to have the opportunity to participate in this symposium today. Thank you very much. I feel like I have one of the easiest jobs of the day. The task for this segment is to explain to you what One Health is. I don't think I need to go into much detail for this group. You know One Health. The previous speaker mentioned the Sustainable Development Goals. One Health and the UN Sustainable Development Goals go hand in hand. They are interleaved and inseparable in many respects. At Oklahoma State, we have programs in our medical school, our veterinary school, our College of Agriculture, College of Engineering, and others that are focused on One Health, and we measure our progress through our progress in achieving toward the Sustainable Development Goals. We now have an international set of rankings for universities based on their efforts and achievements in meeting those goals. And so we are very proud to participate in that and to have been recognized as a university for the accomplishments toward achieving those goals. We have programs to protect water quality and water health. A very important program for Oklahoma, where we are subject to drought and uncertain weather conditions. We have health tracking for our population. We have a population of very mixed people, Native American tribes, as well as other groups who suffer from health disparities and various problems related to diet, obesity, diabetes, diseases of aging, which are very important in our population. We have bioinformatics and data programming, which is important to analyze and interpret and understand the data and report the data on health, both in our animal as well as our human populations. We have a new program in microbiome science to understand the relationship between the microbes that inhabit our bodies and our environment and our own health and well-being. We have a Human Nutrition and Performance Institute related to how human activities in exercise biology and nutrition affect our long-term health, and also these diseases of aging and the interaction there. So all of these things fit within the umbrella of One Health. They all fit within the umbrella of the Sustainable Development Goals. If you think about the Sustainable Development Goals and the complexities that are inherent within them in terms of solving problems, these are a whole series of what we categorize as wicked problems, huge multidimensional, multidisciplinary type problems for us to solve. If you think about the SDG number 1, which is no poverty, poverty typically entails poor housing, lack of food and animal feed, unsafe water, lack of health care, leading to an unequal burden of disease. In this context, we see outbreaks of diarrheal diseases, tuberculosis, HIV, malaria. These are all highly prolific pathogens that affect the human population in unequal numbers based on, in many cases, economic status. We have the SDG on clean water. Globally, we know that nearly 700 million people in the world lack access to clean water, and 2.4 billion have no access to improved sanitation. These people typically will live in rural areas, a majority in sub-Saharan Africa. Providing sustainable water management for those populations is a huge problem, but it's also tied to other sustainable development goals, such as the hunger goal, the poverty goal, and so forth. Climate action is another of the SDGs. Animal and human health are directly affected by virtue of the fact that humans and the pathogens that carry these diseases, or that cause these diseases, the vectors that carry the diseases, have evolved for millennia together under a certain set of conditions. These conditions are now changing, and our relationships and the balances that have been created through our evolutionary history are changing. This is a huge problem, and we must understand how the evolution of the pathogens, the evolution of the vectors is affected by these changes, and what we can do to make life better. So this brings up the idea of what kind of approaches do we take. These are, as I said, wicked problems. Disciplinary research provides some small short-term solutions. Multidisciplinary research can provide some additional changes. The problem that we run into is that these problems are not going to be solved by an engineer or a biologist working together, each coming with their own individual solutions. Everyone must understand the problem at the same level. You all know, I'm sure you all know the story of the 6 blind men and the elephant. These problems are the elephant. How are we going to take care of our elephant when one thinks it's a spear, another thinks it's a rope? We must understand the problem at the same level. So this calls for a version of research referred to as transdisciplinary research, where people come without preconceived ideas, without preconceived solutions, and work together to understand the problem at the same level, so that the expertise of each individual, the tools of each individual discipline can be brought to bear on the problem. Another analogy is a friend of mine and I worked on a multi-transdisciplinary project. And we described our first meeting as everyone came to the meeting with their rock. And they put their rock on the table. This is my answer to the problem. They put it on the table. And they defended their rock. We defended them very hard, very vigorously. And at the end of the day, we didn't have an answer to our problem. We had a bag of rocks. So we want to get past the point of collecting bags of rocks and begin to understand these problems at a much more sophisticated level, bring all of the disciplines together in order to understand. And let's do not forget the social sciences, the humanities. Let's don't forget the historical context, the cultural context that each of these problems exists within. The economics of it will dictate almost everything in the end, because politicians and business people and others make decisions based on economics. Where is the money going to come from? Who's got the money? And then how do we address the problem? So these are all very important components of any solutions that we come up with, and must be considered. So I hope in the discussions today you'll take into consideration the need to look at things in this multidimensional way, and not defend your rock. So thank you very much. It's a great pleasure to be here with you. I appreciate the opportunity.
for that excellent talk and for reaffirming that this calls for a multidisciplinary research paradigm and to think beyond the bag of rocks. And for us to need to bring in various perspectives, including the social sciences, the economical, the societal perspectives and all, which are very, very important. So thank you so much for that. What we will do now is to break for tea for 10 minutes. And since we are running behind schedule for about 10-15 minutes, so I urge you to have conversations or start conversations, have a cup of tea, and please come back here in about 10 minutes. Sorry for the short tea break, and the tea is served right here in the room next to us. So we'll see you all back here in about 10 minutes, maximum 15. And the topic of discussion is innovative approaches to One Health research. I am honored to invite our esteemed chair, Professor P. Yogeshwari, Dean Administration, BITS Pilani, Hyderabad, to the stage to moderate the discussion. Thank you. And I request Dr. J.K. Lakshmi to present the plan to ma'am. Her research focuses on various aspects of medicinal chemistry, including the design and synthesis of novel small molecules targeting diseases such as cancer, tuberculosis, and neurodegenerative disorders. Dr. Yogeshwari has contributed extensively to the scientific community with numerous publications in high-impact journals. Her research often combines synthetic organic chemistry with pharmacological evaluations, aiming to discover new therapeutic agents. She has received various awards and recognition for her work, including grants from the government and private research bodies, which support her innovative research in drug development. Additionally, she has been involved in collaborations with national and international institutions, further enhancing the impact of her research in medicinal chemistry. I now kindly request the chair to invite and introduce the esteemed panel members for the panel discussion, and the topic again is innovative approaches to One Health research. Over to you, ma'am. Thank you.
So very nice morning, very good morning, and I see a lot of students sitting behind and thinking that they're going to get a lot of insights from the speakers as well as the panelists, right? And I just want to make all of you feel ease, because I'm also one of the participants. Though I stand here, doesn't mean that I'm going to preach something which is going to be very important, but this panel discussion is going to be more interactive and it is going to be more simple. There are two reasons for this. Why? I was thinking I'm the only odd person out here, because when I entered IIPH, I was introduced to a group of experts in veterinary science, and I was thinking, what am I doing here? Because I'm truly doing something for human health, and I'm going to be among the veterinary science and I'm going to talk about animal health, right? But then I felt very ease because of the topic that is given, which is One Health, which is for our nation as well as for the world, going forward, because this is what will sustain a healthy world. Because if you are only concerned about human health, we don't bother about what is happening with animal. I'll just give you an example which everybody will relate. COVID pandemic, right? We all worried about when will the vaccine come, when will the drug come, if at all somebody gets COVID in your family. We started isolating them. We were concerned, right? People went through depressions and all that. People who have pets, how many of you have pets in your... This is just a family, right? And then we talk about the community. First, for what we do, what we think, how we react. So how many of you have pets at home? Nobody? There are only two people. Okay, no problem. So when vaccines came, we all got vaccinated, and what about our another family member who is a pet? And people who have pet or who do not have pet have always, one is fear from the animal itself because they don't belong to a species. Second is what will happen if the pet gets some infection, the fur will cause asthma, the pet if they lick you, then you get infection, right? So some of us do not have pets, most of you do not have pets, possibly for that reason, right? So this is one example where we never bother about what will happen to a pet, right? So who will discover? So me being from pharmacy background where pharmaceuticals, biotechnologists, I know what they do as research, but I don't have any clue who will actually discover a vaccine for these animals, right? We are concerned. If the animal gets COVID, one is not a fear that we will get through because we treat them as a loved ones, but what if we lose the animal, right? So that's a fear, right? So we never, first of all our family. Now coming to community, because most of you do not have pets, we all depend on plant and animals for our nutrition, right? Every day we buy milk. Is there anybody who do not buy milk at home? There is nobody, right? Either the packed milk or fresh milk. So how many of us really relate if there is any disorder in the human just because of just consuming milk? I'm not saying milk is bad, good. I'm not here to say that. But there could be a lot of things which can get transmitted through milk. Forget about infection. First of all, we always believe that pasteurized milk are safe. Fine, yes. But what about your metabolism? Do we even think about whether animals get some metabolic disorders? We also talk about as women standing here, PCOD is something which is very, earlier it was not well spoken, now it is very well, visible as PCOD is very common. People think that even a born child can have PCOD. Does animal do not have? Do they not have hormone? And how do we discover drug? If I come from my own research background, first we test in animals. If it is safe, we call this preclinical. Only then we go to the human clinical study. So which means that the animals, once they are safe, all the safety studies we do with animals, and then we go to human, right? So we know animals can develop diabetes, animals can develop depression, animals definitely can develop infections because it's all environment, right? So same thing, whatever the drug I discover, I never thought that I'm developing for animal, I'm doing it for human, right? But why not for animals? So a lot of things, there are interrelated thoughts which is coming. This is only because I'm among the veterinary science, I'm trying to relate, isn't it? So that is what this conference platform has given all of us to appreciate what the other person is doing. They come from different background. I'm not an expert in veterinary science or not an expert in data science. One of the panel member who is going to be joining today. I want all the panel members whom I'm going to call now to be cool because we are going to explore ourselves first thing, what we do, appreciate each other and see how we can collaborate and make this as one of the agenda item because unless you collaborate interdisciplinary, we are not going to achieve anything very close to One Health. We have to connect everything. Biodiversity, it doesn't only mean plants, animals and human, it's also the environment. So during the tea break, we had a small discussion of how all of us, when we all buy medicines, right? We all have a handful of medication, whether it's painkiller or for allergy or whatever. We don't bother about whether this medicine expires or do we even check whether it expires? You check. You keep the whole strip always. We cut, right? 1 tablet, 2 tablet, we always. And then there's 3 tablets left out and we do not know, maybe the expiry date has got torn already. It is not that I'm talking about that expired medicine will harm us, it's not that. Expired or unexpired drug, when you actually put in your dustbin, after that what happens? Where does it go? It goes to your ground, the earth. Do you know how it exploits the water? So the same water is recycled, we drink. We say it is all filtered, RO water. Do anybody talk about the chemicals which are there? We don't think about it. I don't think about it as a researcher, because we think somebody else will think about it, environmentalist will think about it, right? So everybody has their own expertise, own agenda, but today this is going to be a common platform for all of us to promise that yes, I do this, but I'm also concerned about what happens next, right? If I do pharmacy for human health, I also should be concerned about veterinary science as well, right? The same drug, different dose, it might be useful for these animals for as an antimicrobial or anti-cancer or whatever, right? And then what happens to the drug when it is put in the environment, isn't it? That is also your responsibility. We think that somebody else will take care, right? So let me introduce the panelists and then we continue the discussion. Fine? All of you are feeling at ease? I'm not talking anything technically, complicated topic. It is very, very easy topic for all of us to understand and listen. And I want all of you to participate. I want you to ask questions to the panel members so that it becomes more interactive and more engaging. First, let me introduce the first panelist, Professor Raghupati Anchala. He is a Dean Academics, IIPH, Hyderabad. He is an expert of public health and primary care and also a chest physician. Please take your seat, Professor. What is interesting is adapted a program in management and establishing industry and academia collaborations. And he has been instrumental in driving the MPH program, which is Masters of Public Health program, and placement of numerous students pursuing MPH. Thank you, sir, for joining. The second panel member is Dr. Rudra Gowda, whom I met. The third panel member, don't feel you're an odd person in this panel. She holds a master's in biopharmaceutical technology and is a certified base and advanced SAS programmer. Before joining IIPH, she has held notable positions in various sectors, including academia, insurance, banking, and research. She has been serving as a guest lecturer at SRM School of Public Health earlier. Also served as a senior specialist in insurance data analytics at Thomson Reuters Truven Health Analytics, and associate manager in the risk analytics department at Scope International. So she's totally an IT person, but she has a master's in biopharmaceuticals, so somewhere she sings with us, but when I discussed with her during the tea break, she said, please don't ask me anything about the science, I am good at data. I said, please feel at ease. We all will talk what we are best at, and we all will try to connect with each other and then see that how innovations in One Health research can be taken forward. With this, let me take my seat. I hope I'll be given a mic there, or should I stand it?
Take that mic. I can take that?
Okay. So that
and then how do they look at One Health program being an expert in a particular area of research?
Good morning, everybody. I think briefly we'll cover the way forward and the challenges faced in One Health domain from the implementation science of point of view. So looking at challenges in One Health, one of the biggest challenge is the cross-cutting area. I'm audible now?
Keep it closer to you.
Okay, thank you. So, about the challenges faced in One Health domain with respect to implementation sciences. One of the biggest issue with One Health is that it is not although it is a cross-cutting area, most of the domains work in silos. All of you understand silos, but here it is all the more pragmatic from the point of view. It becomes difficult for a scientist working in, say, poultry sciences or zoonotic diseases to talk with other medical people or for example from the public health point of view. So the biggest challenge in One Health that as of right now is that we work in various domains. Although it is a cross-cutting area, we don't seem to function as a team together. The second biggest challenge is lack of a governance framework in One Health. Now by governance, since I'm working in the operational domain of public health national programs, all of us understand the importance of a key architecture under an umbrella framework. When we work with the governance mechanisms in mind, we need to keep in mind that if you do not have a clear-cut objective and values attached to One Health program, then it is bound to flounder in the areas of implementation sciences. So second biggest challenge is lack of a framework of governance in which the objectives and values are not clear-cut to everybody. So with these two challenges, the third biggest challenge which I try to pen down in my decade-long experience in national program is the 4 C's of any kind of national program, be it the coordination, be it the collaboration, be it the communication or capacity building. Now all the 4 C's which are mentioned are challenges and also show us the way forward if you want to improve One Health functioning in the government system. In terms of collaboration, usually the North-South collaborations drive most of global health agenda. And since global health diplomacy is picking up, we have seen wonderful examples from Philippines which work in the area of One Health. So way back in 2020, the Philippines government called an expert panel for all One Health people, and they all understood that we need to change the nomenclature of community health worker to One Health worker. So this is an exemplary example of trying to build up capacity for frontline healthcare workers in the One Health domain. By this One Health worker concept, in which they have renamed the community health worker as One Health worker. So this One Health worker not only works on the medical data frame, but also works on sociological and community point of view. What they have done in Philippines is an example in trying to make sure that community is at the focus of One Health. So using principles of sociological sciences, all the students must be aware of community diagnosis, in which we try to understand what are the needs of community. So this high-level technical committee in Philippines had commissioned people even from society as a part of that particular team. So using the grassroots workers, they try to find out from the community what is their viewpoint of One Health. And they were shocked to know that the advocacy and awareness of One Health was almost minimal in the population. Just like all of us scientists, experts working in One Health domain, all of us are very good in the medical science of One Health, trying to find out what infections can happen, what pandemics can be triggered by lack of appropriate framework and structure. But if you don't involve the community as a part of One Health programs, then they will not be in the longer run sustainable. We have talked about sustainable development goals, and all of us need to understand that sustainability is the key of One Health program. We have seen programs, national programs in tuberculosis, HIV, they have taken up to a different level because they involve the community. The national program for NCDs also is trying to work on trying to involve people living with NCD conditions. So utilizing community is a good example as a way forward in the One Health domain. And last but not the least, such kind of examples of good case studies need to be discussed much more in the One Health forum. So as I mentioned, collaboration, South-South partnerships. So Philippines and say Cambodia have partnered for One Health program. There is a scientist called Professor Renzo Gunto, who has joined Duke University in Singapore, and he has coined a specific term. I mean, it's a term known to all of us, but he calls himself a planetary scientist. So when I interaction with him, what is this planetary sciences? It's nothing but One Health, in which they try to cover all the domains of One Health under one umbrella. And he has implemented that program in his own country of Philippines. And this example came while I was discussing with him on the One Health concept. So that's a way forward for us to involve the community and also to make sure that we have the objectives and values clearly lined up. So as I mentioned, I would summarize that the 4 C's are very important in One Health domain. Capacity building of frontline healthcare workers, in which they try to understand what is the importance of One Health from medical and non-medical, by non-medical I mean sociological point of view. So if you build the capacity, then collaborations, communications and coordination are easy to follow. Okay, with that I'll take care.
Good afternoon everybody. My name is Rudra Chanapanawar. I'm a veterinarian by training, far from here. I graduated from Bidar Veterinary College, just 3 hours west of here. I'm from Karnataka originally and did my master's degree in veterinary pathology from Indian Veterinary Research Institute in IVRI, Bareilly, Uttar Pradesh. Then I went to US for a PhD, and then I did the postdoctoral studies, and for the last 5 years I've been a faculty member, initially at University of Tennessee, and then now in a College of Veterinary Medicine in Oklahoma State University. So thanks to Dr. Cole for organizing this meeting, and thanks for all those who were involved in organizing Ms. Roshni and Dr. Tedalavi as well for facilitating all of this work. We're really happy to be here to share our thoughts on One Health and the innovative approaches. So what do? I'm a veterinarian, but I work on human pathogens, coronaviruses. I have been working with coronaviruses since 2012. It's been 12 years I've been working with coronaviruses. I initially worked with SARS coronavirus, then MERS coronavirus, and as the pandemic hit, we all got on our gear to work on SARS-CoV-2 as well. I'm a virologist and viral immunologist by training. The specifics of my work is to identify why these viruses are pathogenic in humans as well as in animals, and what can we do to develop new therapeutics to treat these animal as well as human coronavirus species. And now I'm more respiratory infection guy, and not only limiting myself to the coronaviruses, but we're also studying several other respiratory viruses. And I also work a lot on vaccine development, preclinical models specifically. I have worked with some companies as the pandemic hit to test their vaccines, antiviral drugs, and we provided the results for them to take them forward for human clinical trial. So in a nutshell, I'm a veterinarian who works on human diseases. I kind of have expertise a little bit on zoonosis and zoonotic diseases and how to prevent them. And by that I mean how to prevent infectious diseases both in animals as well as humans. So as we go along, I'll share some of my thoughts about what can we do to protect One Health, health of animals and humans as well as our ecosystem that we live in. So we have some points I have made, which as we get along, we'll discuss those points. Thank you so much.
Good morning. I'm from Center for Digital Public Health, IIPH Center for Digital Public Health. So here I'm going to discuss about the data management perspective of One Health. So this One Health is an interconnected and they are interlinked. I see it as a horizontal perspective of interlinking the data. For which we need a database. To have a proper robust database, we have to collect the data. So through this program, it will be good, we connect and collect the data from the from various institutes around. So the database becomes robust. Once the database becomes robust, we can send bulk SMS alerts to the people who are affected, not only the people who are affected and also the intersector. For instance, there was a bird flu outbreak where not only the concerned affected veterinary people but also the humans were affected. So we can send bulk broadcast messages, alerts to the people who are affected. And also we can have a model so that we can address the future outbreaks. So through this data visualization and analytics, we can have a proper insight of the diseases. Apart from this, once with the database we have created, we can have a technology like various GIS and Panda like that, and we can analyze the data, and we can have a data integration through which we can monitor and analyze the data, evaluate the data. Here comes the data governance. The data governance means how securely and how safely we handle access the data. By this we can have the open data platform where we can have the we can have interdisciplinary collaboration of data and analysis. So for which we should have a frequent meeting and discussion so that we can create a robust database. Thank you.
Thank you, scientist, and then we also have a data, handler. Now, since we all of us can connect to the pandemic, everybody, people who are not even, layman became doctors because of WhatsApp. Forwards, people can read what is COVID. They talk about COVID more than the experts itself, right? So I just want to, because it's innovation, I just want to put to the panel members to give their thought about the pandemic, which everybody have got exposed, right? We all knew how it was broadcasted, what was happening throughout the world, because news channels, social media, we are in that era, right? So I just want to ask the panel members one by one, just to share a thought, what could have been done better during this pandemic if all of us as stakeholders of One Health would have worked together, both the data scientists, veterinary science scientists, public health workers. What would have been better? We don't have an environmentalist. I think we should also think about it, because this is my perspective is we all try to protect people. We started talking about social distancing. We started talking about what is the importance of wearing a mask. But then, though it was followed, not followed, that's a different thing. There are even cameras made, AI cameras, which can even detect in a group of a big crowd if somebody is not wearing a mask in airports and all that. So people could even get the temperature sensed at a distance, right? The airports have a lot of cameras. So a lot of technology is used, a lot of data broadcasting happened. But I don't think we worked towards something called as a sustainable One Health concept there, right? Because it was a pandemic, it was not expected. But having seen what has happened, what has happened well, what has happened not well, I just want to ask the panelists, if at all we all came together to work together, integrated our thought processes, what would have been better, what would have been avoided?
I think the COVID-19 pandemic gave us this term of infodemic, in which data was quite fictitious. So the data platforms, even though they were running in real-time basis, did not portray real-time data from different parts of India. So that led to a communication barrier between the community and the scientists working the COVID-19 platform. Now, from public health point of view, I think if we all work together as a team perspective, it's important for us to portray the importance of correct communication channels. Who should communicate, what should be communicated, should be very crystal clear in black and white, so that the community at large knows in general what are the potential early warning signals which need to be taken into account. Second big thing which COVID taught us was the importance of coordination between different sectors. The medical sector was galvanized into action based on the COVID-19 pandemic. But what did not actually take place was the infrastructure backup in the second wave. All of us saw dead bodies putting down the Ganges River in the eastern part of UP. So such kind of scenarios could have been avoided if we had planned better based on infrastructure requirements for which we were not adequately prepared. And that will come only if it's a unified command center which will have all the actionable elements required, so that an actionable report can be portrayed to the community at large, and the community and the scientific experts can work as a team together to prevent further outbreaks in the future. And the third thing which was very important was the usage of GIS platforms. It was a novel idea which came from some countries in the Western world, but India took a lead in trying to portray early models for what will happen if prevention steps are not taken. So some parts of India like Tamil Nadu, Karnataka, and even Telangana and AP developed GIS models based on early prediction patterns. It showed us if the pandemic is controlled in X point, then the wild population will not be affected. Such kind of data generation is very important to build future communication models for the public at large.
Thank you. So from my perspective, as someone who works on infectious diseases, I think what could we have done? I think one of the necessity was the clarity in the message that the administrators as well as the health professional provided. was no clarity and there was no consistency in the message the public got. As a result, there was always a confusion or a question, and the regulations were not properly followed. So that was the one which I think was important. And I also see not only for COVID-19, SARS-CoV-2 virus initial period, but also for a lot of animal diseases. We don't report a lot of diseases. There are still a lot of animal diseases which researchers know they exist, but we don't report those to World Health agencies or other regulatory bodies. For some reason we hold those back for a political reason or some business reasons, the export and import of the product, meat product and so forth. I think those could have done better in those kind of proper reporting of initial cases of the COVID-19 and how much really was. In fact, I think that could have been a really important step taken to alert the seriousness of the disease, which we did not do initially, both in the US as well as in India. I think that would be an important point. Another key aspect would have been funding from the government and public health agencies for diagnosis. There was a lot of issues. The diagnosis was not done properly, on time, because there was not much funding. There was no health professionals or diagnostic people who could, do the diagnosis early on, provide the results, and so that you have to take care of these people. Funding for research is still a concern in subcontinent, and funding for public health agencies. I think that's one of the biggest problems. If there was funding, there would be more professionals, and there would be more guidelines that are being developed. That would have been really important. Education of public on public health, zoonotic health. I think one of those public health officials can do and can do much better, where you tell them how to protect yourself in case of an epidemic or pandemic or even small or sporadic outbreaks of the diseases that one can do. And I think a kind of clear, streamlined public health infrastructure, I think could have been better. I hope we have learned our lesson from the pandemic. If not, I think we will be ready for another pandemic. A streamlined, cutting the red tape, public health infrastructure, clarity in the message from the public health perspective. I think that is really important for us. Just to give an example, we had a colleague in North Carolina who worked with the mayor. The person I worked with during initial years of coronavirus was one of the leading experts in the world. He still is, my mentor, Dr. Stanley Perlman. And there was another lab in North Carolina, University of North Carolina, Dr. Rob Barrett, so whom I know well. They published a paper probably in 2019, or 2017 if I'm correct, where they did clearly write in their paper that they have identified the coronaviruses in bats that can bind to human receptors and they can jump into the humans, may cause pandemic. The signs were there, but the public health people did not listen to those signs. So that I think public health officials and the politicians I think need to more listen to what researchers say and follow up on those. I think those are few things that could have done better throughout the world to prevent the pandemic. And these are necessary to prevent these such pandemic or epidemic occurring in the future as well, from my perspective.
One here, for which I feel we should have a interdisciplinary collaboration with the various institutes. So for which what is important is to understand the data governance. Data governance means how we are ethically and responsibly sharing and accessing the data. So once we understand the data governance, we can definitely work on open data platforms where we can collaboratively analyze and research the situation, the pandemic, outbreaks, whatever it is. What we want is we have to have a frequent meeting and we have to construct our database a robust one.
Small and within the community that we work. In case we all of us, along with environmentalists, social workers, social scientists, economics, professors or scientists come together how do we start? What are the checklists that we need to do to start small? You can give briefly few points. If we start building One Health as a program for creating a healthy village, to start small, what is the checklist that you will start looking at when we all come together?
One key change required is community empowerment. As I often said, that is community, it depends on how you interact with the community. So if you're starting a healthy village concept, it's important for the community to be equally empowered about the early warning signals and what needs to be taken to prevent such episodes in the future. The second thing which we must advocate for is having a good infrastructure at village level in terms of program management. Though the health system has got adequate infrastructure and adequate personnel, not everybody is competent enough to understand and appreciate the importance of One Health. So when we go back to our training, it's important for the frontline healthcare workers to be equally empowered with what are the required competencies to provide good One Health support for the village. So one is community diagnosis and second is to empower the frontline healthcare workers with the required competencies for One Health management. Sure.
So I just want to, I think at the village level, I think we need to have a better health system and diagnostic system to identify the diseases that may come up, and so that those can be reported and further action can be taken to prevent the transmission of these zoonotic and other diseases.
So the CHW should be empowered with the latest technology and mobile, how to create the work on the application, how to fill the data properly using mobile. So that is very important because what they feel is very crucial to understand the situation better.
Information, because we are veterinary scientists, public health worker, data scientists. I know that everywhere we have primary health center depending upon community population, right? But do we also have a system where to report environmental, like say for example, whether the drinking water is safe, hygiene? Does the primary health care takes care, or do we have system where there's a reporting of environmental toxins available? Second is also about the animal health. Do we also have primary health care units for animals in that community?
To answer this question,
Don't you think it's important?
it is very important for sure. Whether we have it, I don't know. So, because I've lived almost 17 years in the US now, so my apologies. But having said that, we definitely need systems. I can give you a couple examples here. So what are we doing after the pandemic in the US? So now we have established a really good surveillance system. So what does that mean? It collects the samples from sewage that are centrally collected in each counties, each towns. So they collect the sewer. They collect it and isolate, RNA, DNA, and sequence it. So one of the advanced technologies now that we are doing. They sequence it to identify, for example, during coronavirus, the coronavirus was changing. There was one variant and the next variant and the next variant. There are a lot of researchers who are collecting the sewer samples, both from animal sewer sheds and human waste, excreta, and so forth. Sequence those samples to identify if there is a prevalence of one of the variants. Is there a new emerging variant coming up? And we are still doing that. Those systems are giving us a clue that someone in this big population in the village or in the district level or state level, someone or a group of people are infected with this virus. This virus is circulating and it may emerge, it may transmit to the different individuals, and sometimes it may even transmit back to the humans, animals. So I think that kind of surveillance system probably will be really helpful. It takes some infrastructure build up, but I think that can be done. That helps us to track these different variants or new viruses or other bacteria, other pathogens, to detect these pathogens and promptly report them and maybe prepare for the emergence of this disease into humans or from humans to animals. I think that's one of the things we could do to really help them. And again, data scientists are really key here because they analyze the sequences and identify what kind of pathogen is this one. So those will be helpful. I think if we can implement, if we haven't already in here, that would be really helpful to track the new pathogens and maybe take corrective measures against those pathogens.
So like I would like to share an example. There was using spatial data analysis. We collected like dump sites where the sewers are dumped. We collected the points from the corporation, and we thought we will analyze the health of the people around. And later we found using GIS that the dump site was not the particular site where they had mentioned, and it was in the various other places, and it didn't work. So GIS really helped us to really exactly locate the dump sites which are not mentioned, which is not part of the list which the corporation has. What is in reality doesn't match with the data that is available. So always I emphasize on data, which is very crucial.
Can we open this panel for audience questions? If there is anything to discuss, any curiosity, driven questions encouraged.
Of building the database, what kind of data is necessary for monitoring One Health? Do we have a list of required data, or does it have to be worked? Any idea on that will be really good.
We are actively working on creating a database for which we need to have a collaborative approach with the various institutes. So for which we have to first understand the data governance, like what has to be shared and what not be shared. So this is the inhibition that everybody has before sharing the data. So once we have a proper guidelines, which ICMR and also ABDM is working on, once we understand and we empower ourselves data governance, definitely we can work on it. Thank you. Hope I answered your questions.
Are the variables understood? Measures. When you think of One Health, it's really life. And the foundations of all those outcomes are also important to understand. So people's beliefs, behaviors, practices, how they're interacting with plants, animals and chemicals in the world. So we need some research on that as well, rather than just focusing on diseases and amounts, parts per million in water and so on.
Lot of initiatives, lot of thought process, but then we are living in a diverse country, and village to village there will be behavioral changes, practices, beliefs and all that. I think that is why I said if you start small, start with one community, do a complete data analysis, surveillance is one point which is common. I think somewhere we have to start, right? So yeah, good question. Thank you. Yeah, so I'll take that as the last question.
Who's also in working in human health. Is there an understanding of the level of transmission from zoonotic to human health? Is there well done research which gives us the risk prediction of what are the kind of transmission that happens and what are the factors that impact this transmission, and what does the current science say, and what are the kind of risks that are involved? Would be good to know. Thank you.
But I did not bring it up. So we do. The answer is yes and no. Yes, because we have recently, last few years, have done a phenomenal job collecting the data from both animals and humans that are about the viruses and the other bacteria and other infectious diseases, where there is a lot of pathogens have been detected that were not initially identified. But that being said, because of our encroachment into environment, and interactions with wild animals and exotic animals, there are a lot of animals that harbor a lot of different pathogens. Just to give an example, there was one study last month in Nature that was published, since I'm a virologist, I can speak to that, that the researchers from China as well as US and Australia, they collected samples from a whole lot wild and exotic animals. They found out several hundreds of viruses that are not known to infect humans that are present in those animals. And these animals are reservoirs for those, and they have the potential to jump from animals to humans, which we did not know initially. So there are efforts going on in that direction, but I think from each perspective of each country, the animal population, whether it's exotic, domestic or so, is quite different, and they may harbor different pathogens. So I think one of the efforts should be to collect different samples from different animals and perhaps from humans to animals too, and try to identify if these pathogens potentially have the ability to transmit from one species to another species, and can they cause disease. Definitely those efforts are there, but it need to be more, and we also need to be aware of our ecosystem to not to try to interfere as much with the natural kind of system. You know, the more we do deforestation and so forth, the more we're going to find these out. But again, it's really important to identify, sequence samples from these tissues and others from fecal samples, others from these animals, and try to identify if they have the potential to infect, and perhaps do some preclinical studies to be prepared for those kinds of studies.
Just a small follow-up. Is the science to understand how it leaps across species, is that well laid out? So are we able to predict what is that, if you get all the samples and the data, is that then the follow-up steps easy to understand or predict? Is that
so? The system is established,
okay?
but we're seeing new challenges for those which is not established. For those which is not already, or for those it's well established. The one they gave you hundreds of viruses.
Right.
For those they need to know whether they can transmit from humans to animals, and they can bind to human cells or not. Those are established. But there are a lot of the viruses for which we don't know. That's why the answer is yes and no.
Thank you. Thank you.
Professor said, many of the virus diseases in India, I worked with one virus for drug discoveries, Japanese encephalitis virus. So when I was collaborating with a doctor in Bangalore, I was curious to know why are we even talking about Japanese encephalitis virus in India, because this is 20 years ago when I started working. So he told me this interesting story. This virus actually was through a migratory bird, right? The farm, which used to come and settle in a farm, and the farmland, the water, all got infested. So there are many things that is we do not have data or source for it. And currently, since we are with a lot of integrated digital literature is available, I think it's easy for us to now track, as what she said is, how does the virus adapt or mutate to even survive in human, because that is something which is interesting in science. Thank you for answering and thank you for asking those questions. Just to sum up, I'm so happy that IAPH had given this platform for all of us from different fields to come on a single platform. And since the topic is innovation, whatever we do in India will be innovation, because there are, for one hand, we are very, very far, because for the first thing is the expert itself has to come together, right? We are comfortable with working with the same kind of areas, same kind of researchers, but I think this platform, I have decided that I will, push myself to interact with veterinary scientists, social workers, to understand public health experts, to see that how a small community can, we can start small, and that is why the question came up, just to see the checklist. Innovation, bringing people from diverse fields itself is an innovation. This panel itself, I feel that for us to understand each other and what is our different perspective itself is novel for all of us. And I thank all the panel members. And one thing that I want to appreciate, which Professor Raghav brought in, is instead of we labeling us as medical doctors, human or veterinary scientists, it is always good to have a professional called as One Health professional. So that, which means that the professional do work with, integrate, they work with other experts, and they know what is the next step, right? Instead of saying that this is not my work, to worry about expired medicine put into the environment, I will know whom to connect, right? So that's a good thing that is a takeaway for me from this panel. Thank you very much for patience.
I thank the chair as well as the panel members for that wonderfully made points. And we saw that we got various perspectives from the pharmacy background, from the public health background, from the veterinary sciences background, as well as from the data sciences background. So that tied in very well with the topic itself, which was innovative approaches on One Health research. So now it is time for us to move on to the second panel for the day. We have two panels actually before lunch now. So I request the panelists as well as the chair to please see that if you can wrap it up in about 40 to 45 minutes so that we'll be in time for lunch. So now I will go ahead with the next panel. I am honored to invite our esteemed chair for the next panel, Dr. Raman Muthuswamy, SIMATS Chennai, which is Savita Institute of Medical and Technical Sciences, to the stage to moderate the discussion which is on emerging infectious diseases, a One Health approach. Dr. Raman Muthuswamy, please sir, and I would request Dr. Raghu to give Dr. Raman blank, please, while I do the introduction. Dr. Raman Muthuswamy is currently a research professor and cluster head of One Health and AMR with 36 years of experience. With 36 years of experience as teaching and research faculty in the Tamil Nadu Veterinary University and Savita Medical Sciences University, Chennai. Professor Raman led 26 extramural research grants as PI, funded by British BBSRC, UK RI, as well as US-based BMGF and NIH, DBT, DST and ICAR. His major One Health project includes GCRF, One Health Hub, led by Royal Veterinary College UK, and TMRC NIH grant, led by CMC Vellore, and ARC Discovery Project, led by Australia National University. Professor Raman has been awarded the Best Scientist Award by the Tamil Nadu State Council for Science and Technology in 2002. As well as Biotechnology Overseas Associateship Award by DBT, Government of India in 2006, as well as the Best University Teacher in 2006. He has an unblemished 60 plus years service award by the Government of Tamil Nadu in 2019, the Best Scientist Award by Savita University in 2023, and he is the Fellow of Antiviral Research Society 2024 awardee, to mention a few. He is also an editorial member of JAC AMR Journal, Frontier in Veterinary Sciences, International and Indian Journal of Public Health. Now I kindly request the chair, Dr. Raman, to please invite and introduce the esteemed panel members for the panel discussion, which is Emerging Infectious Diseases, a One Health Perspective. Thank you. Over to you, sir.
So, good morning to everyone. So, because we are already a bit late, so I am making it short. So, the topic that we are going to discuss are emerging infectious diseases, a One Health perspective. So, why do we need One Health perspective for emerging infectious diseases? You all know that when we have veterinarians and medical physicians, why do you need One Health? Because basically the emerging infectious diseases doesn't mean that the diseases which are infecting only one person. But now we saw that just example of one viral infection, COVID, where we had to call everyone on to manage the situation. Right from the physician, the public health personnel, the doctors, even the civic authorities, policemen, and even public. So the emerging infectious diseases need not be unique. You need not be a single host. For example, we have been in the football disease. We heard about football infections. Since football infections, do you think that it is emerging? It is emerging. We consume a lot of meat, for example, chicken meat. So, in fact, in one of my research grant, I was working in the value chain of the commercial chicken. So, what happened? These commercial chickens are fed with growth promoters, and some of them add some antibiotics as a growth promoter. So, what happens when these chickens are fed with antibiotics over a period of time as growth promoter? They end up with resistant pathogen in their gut as well as in all their value chain. So these chickens, when consumed by humans, and we love chickens, most of us, right? So what happened that these resistant pathogens are carried away to us. So this is just one example. So it may happen in any food animal. Because as you know that there is no strict implementation of dispensing of drugs over the counter. If you want to have some drugs, you can go to any medical shop, get it over the counter. So this is when this is very common in humans. Think of farmers who are located far away from cities. So when they have some problem for animals, the first thing is, though the veterinarians are available on call, but still there are time. So they have immediately approached the local pharmacy or the person who dispenses the medicine and then get the antibiotics or drugs without knowing the consequences. So this is definitely an emerging infectious disease. Don't think that it's only the viral pathogens or even bacterial pathogens. And I have been working on Mycobacterium tuberculosis. You all know tuberculosis is very common in human beings and animals. See, the government of India and the entire world is now trying to eliminate or eradicate TB. But we come to know that the Mycobacterium species which is present in human comes from animal. But we never know the Mycobacterium tuberculosis, which is the species of human, also transmitted to animals. And in fact, we have been working on this tuberculosis problem in animals, especially in shelters. You all know that in India, most of the dilapidated animal are animals which met with an accident or disowned animals. Where do they go? Where do these cattle are taken? Have you heard about goshalas? Shelters. So these shelters are, it's a concentrated place where hundreds of thousands of animals. Even in the city of Chennai where I live, we have a place where we have 4,000 plus animals in about 10 acres alone in animal shelter. So what happened? These background of these animals we really do not know whether they suffer from any infection or they carry any infectious pathogen. But all these animals are kept together in a small place for a longer time. So what happened? These pathogens get exchanged between themselves, and not only that, to the humans who are going as a volunteer or sponsors. They go every week, weekends, go to the goshalas, help by feeding the animal directly. You see, it's very common practice. People always feed the animal fodder or some greens or banana, they directly feed. So what happened? There is no control of access of these humans or volunteers to animals routinely. So we found that even among the mycobacteria, we were thinking only M. tuberculosis to animals and Mycobacterium bovis to human. But we found pathogens like Mycobacterium orygens, which is basically never considered as zoonotic. Now there are a lot of evidence has been generated both in the animals and also in human. It is not just that we happen to normally do a lot of post-mortem in the veterinary college where I worked earlier. So we normally get a lot of deers which are accidentally killed or which died to some diseases in the Gindi. In Gindi we have the official residence of the governor of Tamil Nadu, where it is a lunch space for the entire Chennai. So there are lots of deers. So some of these deers we happen to do the post-mortem and found they carry the Mycobacterium oryges. So how do these Mycobacterium oryges enter into the deer population which is in a protected area? This is governor residence. How do they enter? So this is exactly what is happening in the environment. So emerging infectious diseases doesn't mean that animals or humans, but also environment. In fact, I was talking to Madam, the Joint Director, that the environment is the common platform that we are using, the plants, the marine, the human, everyone, animals. So what happened? We are indirectly spoiling the platform, the common platform. So the emerging infectious diseases, it's a very broad terminology. So naturally, this needs a multidisciplinary One Health approach. Otherwise, how can we control or manage the kind of the pathogens or the emerging infectious diseases that might come through foodborne or vector-borne? Say for example, I have been working on a government-funded project on filariasis. You all know about filariasis, human filariasis, and animal also have filariasis. What happened? We were randomly screening the blood samples of the canines, dogs in certain parts of Kerala and Tamil Nadu. We found that some of these pathogens originate from human. So we found some of the third stage infective or the infective larvae stages of these filariates in the dogs. Because the vectors are common. It could be sometimes accidental finding, because when you share the platform with the pet animal, especially somebody is asking. So when you share, naturally that the vector are same, the hosts are same, they need a mammal. So that these emerging infectious diseases have literally no boundaries. That's why there is a word called risk anywhere is risk everywhere. Don't think that any infection, see we came to know that an infection occurred about 5,000 miles ago again in Wuhan. It went up to the North America. How? Within few days. It doesn't mean that risk in a place, it's not restricted. So unless an One Health approach is implemented, it is very, very difficult to manage the emerging infectious diseases which may come in any form. It could be a foodborne, or could be a vector-borne, or environment form. So this particular panel has been very well formed thanks to Professor Anil Kaur and the team. That I have three members. One is Dr. Sumitra Nair. She is the Joint Director of National Program for Climate Change and Human Health under the Government of Telangana. Welcome, madam. She has got an extensive expertise in public health and climate resilience. Dr. Nair leads initiative to address the impact of the climate change on human health, particularly to the vulnerable communities. Her work involves developing policies and strategies that integrate environmental health system, focusing on disease prevention. Dr. Nair's leadership and commitment to sustainable health program have been instrumental in advancing Telangana public health response to climate change. She is an advocate of One Health approach, emphasizing the need for collaboration across sectors to mitigate the health impact of environmental changes. So when we talk about the environment, even the previous speaker was telling that when you screen the water sample across stream, from upstream to downstream, we may find different type of bacterial pathogen which might or might not be contributed by one host. There will be several hosts. In some point, animals may contribute some pathogen. At some point, even wild animals. At some point, the human being. So the climate environment is more critical than any other factor. So we need definitely people like panelists like Smitra Nair. Welcome, madam. And then I have the second member, Dr. Sunil More. Welcome. So he is a veterinary pathologist from Oklahoma State University, and he is currently working in Oklahoma Animal Disease Diagnostic Laboratory, and he has been working on a lot of viral pathogen and secondary bacterial infections, and he began his academic journey in India from Nagpur as Bachelor of Veterinary Science and Animal Husbandry, and then followed by Masters here in India, and then he did PhD in Biomedical Science in Oklahoma State University. He researched the influenza virus host signaling pathways during his PhD. He also residency completed in anatomic pathology in the University of Florida. So he is a diplomate of American College of Veterinary Pathologists, which is a very prestigious certification in US. And so welcome Dr. More, and he is very much representing the animal health. So we have Dr. Chowdhury from IAPH, Hyderabad. Welcome, sir. So he is working as associate professor here in IAPH. He is passionate about teaching and research, and previously he has served in many ICMR, National Institute of Epidemiology, Apollo Institute, and also in CMC Belloor, and also in Government of West Bengal. So his research interests include primary health care, infectious disease surveillance, and core epidemiology. So he has got more than 50 publications in national and international journals. He is also editorial board member in PLOS Global Health Journal. So we have a right combination of members representing the climate and environment, the animal health, and the human health. So now let us move to the panel. Yeah, this is a most neglected area. We think that in many of these programs, the role of the environment and climate change has not been stressed much. We will be talking about lot in animal health and human health. But what are the critical points or critical parameters that you insist upon as an environmentalist or climate specialist?
Thank you, sir. So being from the government side, as well said, everybody was discussing about what to be done, what can be done and all, but especially when a disaster has occurred, when climate change has occurred, maybe it is a floods, maybe it is a heat-related illness, maybe it is an air quality change. So what happens at that time? First of all, the community is closed up, they don't even have contact with others. We also cannot approach over there. So the community itself has to know what is the problem and how to treat that. Because all the information, broadcasting system, everything is stopped, it's halted over there. So then comes what to be done. So maybe here the one human health not coming from outside, but from the community, they have to know what to do. Maybe the medical officer over there, maybe the veterinary officer over there, maybe the community, the frontline workers should have the awareness what is happening, what can be done over there, how they have to treat, how they have to come out from there. So for this I would like to give a better example. Recently what we had because I am from Telangana, so I will be telling a quoting example of my own district, Bhadragi Kottagura, where we recently had floods. So that pocket, some certain pockets were completely shut down, they couldn't come. So we had the vulnerable population, not the entire population, even vulnerable were the pregnant ladies, small children, old age people who were taking the diabetic medication, hypertensive medication, everything coming to a halt. So then what our system, what we have to do over there? Are we able to go over there? We are talking so much over here. We are not able to go over there. So the awareness comes. I am very thankful, or my commissioner sir himself has gone over there to see over 2 days. He has seen in such a way that maybe through boats or whatever possible, we will try to reach over there. We shifted the vulnerable population from there to the nearby areas, the pregnant ladies who are ready for deliveries, and even the old age people who are literally they can't even move out, the debilitated people taking care of them. But this all happening, when it has happened we have done that. But what did we do prior? Maybe this setup, this stage should also look into that aspect. What diseases will be emerging when there is a change in the environment? Maybe a high temperature, maybe floods, maybe whatever it is. So this is where the environment system will come into picture. Their help is always required for us, foreseeing what will come in the future, and if at all the disaster has occurred, what best can be done from the community itself.
because at that moment we will not be able to reach over that place also. At least a prior, if we know, maybe we can shift them. If all of a sudden it has occurred, what else? So in that aspect, recently we also had an orientation program from Government of India, where from the NPCCH department they have come over, they have given the capacity building to medical officers and also to the nodal officers. See, we have identified for each district from now onwards, we will have a nodal officer who will be taking care of the NPCCH and also One Health. But of course, because this One Health is a newer domain, we require capacity building to our professionals. And secondly, in this orientation, we have identified the nodal officers and told them what can. First of all, you identify your scenario or your place which is prone for which kind of climatic problem. Because you know some areas will be having for rivers, so maybe floods is possible over there. Or there are some places where we have coal mines, so high temperature is a problem for them, where we have more of heat strokes, heat related illnesses. Or maybe some other place where we have extreme, especially the extreme winters, when we have the asthmas and all the air related illness coming up into picture. So during this time, maybe the climatic variations, definitely the capacity building, not only to the medical officers but also to the frontline workers. That is, it has to go up to the level of the ASHAs and our ANMs who are there for the every 5,000 population. So only when we are able to spread this, the prior awareness, yes, then we are ready to take care of any kind of the disaster, any kind of the environmental change. So this is all from my side. Thank you, sir.
Madam was telling about exactly what is a package of practice. You need a kind of SOP, because it's very difficult to draw an SOP for this kind of climatic changes or environmental, because it varies from place to place. Unlike the specific infections like viral borne or bacterial or vector borne, these climatic change or the environmental changes might be very unique. It could be a kind of landslide, or it could be a kind of flooding. We have also recorded that, especially we heard about snails. These snails are small arthropods. So when there is floods, what happens? These snails are literally taken away to far off places, and we have recorded a lot of outbreaks of diseases due to fasciola. So this we have seen it in the foothills of Tamil Nadu, where we never see such diseases in animals. How do these occur? Because these snails have been washed away from Nilgiris and then come down up to the foothills where the Coimbatore is, the other places are located. So we saw that these diseases will never occur here in animals, but the floods have changed the entire scenario of the epidemiology. So that means these kind of climate change environment is very critical, and as she rightly pointed out, we should have a package of practices or a kind of unique SOPs, which is very difficult. We should have action plan, but for which we should have enough data or previous records, based on which we can draw, and that would be definitely unique. Thank you, madam. Thank you for the wonderful, substantiation. And Dr. Sunil More. So, what do you think that how this animal health, if we keep the animal health, well, we say animal health is human health, right? But how do we put it into practice? How do you keep it in practice? For animals, you can definitely do vaccination. Then what about in other ruminants or farm animals? Or some animals like very domestic, which goes to forest for grazing and come back. So these animals, how do we generally these can be put into practice? Yes.
Thank you. I'll tell you what I do first, and then I'll answer the question. So I'm one of the veterinary pathologists. So my job is to diagnose diseases in animals. So if your animal comes to me, that's bad news. I look at the biopsy, that means cancer, right? And then another thing I do is I do postmortem for the animals. So when these animals come to me, there are certain ways I look into this problem, like why this animal died. So there are typical diseases that animals get. And so I look at that animal, I open the body and see, okay, this disease is commonly seen, it's a bacterial disease or this is a toxicity or something. That's good. But when I start seeing the signalments from the veterinarians that, hey, we have these unexpected deaths in these birds or cows, and we have seen this, right? And so when I open the bodies of these animals, and if I see a lot of hemorrhagic lesions, that triggers me like, hey, I need to do something beyond normal diseases, right? And so, so I'll give you an example of influenza virus. We have this H5N1 detected in geese. And so in Oklahoma, these are migratory birds that come to Oklahoma during winter. It is not harsh. But we have a pond in our university, and we saw this as there were time. And so people, when they see these kind of things, they submit to our diagnostic lab for necropsy. And so when I did the necropsy on these 4 or 5 birds, I saw a lot of hemorrhages there. And I was wondering, if what are the diseases that can cause hemorrhages? First thing that comes to my mind is a viral disease. And these are wild geese, and so influenza virus was on my radar, and I asked Akash to run a PCR, and those all came positive. And so that's the first step in diagnosing diseases. And so I'm blanking on your question about how we. So can you repeat the question? Sorry.
Yeah. How do these animal health, maintaining animal health, is going to directly, so for example, if it is effectively it's fine that we keep the animals clean. But how do you make it in the rest of the farm animals, and those animals which goes into forest will come back?
So we do surveillance. We do 2 different types of surveillance. There's active surveillance in animals, where we deliberately go and monitor look for diseases, right? So we do rabies virus testing in different canids and different animals. Then we do Western virus testing in mosquitoes. Is that coming up? We do salmonella pudran testing in poultry chickens. And then there's passive surveillance that I talked about, where we look at the animals and see, okay, is this animal fitting the normal diagnostic criteria, or is it something different? And so when we talk about these wild animals, I'm actually dealing with one of the cases here. So we have these deers that are used for hunting, right? And so there are big farms in Oklahoma that you pay and you go hunt deers. However, these farmers are experiencing mortalities, especially the newborns, right? Either they're stillborn or they die soon after birth. Now the problem is their moms also die, okay? And so none of the males are dying, only the females and the kids are dying. And so when I'm looking at that problem, I feel like that problem is very unique. It's affecting only one population, right? And so I still don't have answers from that one, but first thing we did is we ruled out all the infectious diseases that we want to see in a deer, and so unfortunately it's not there. So those kind of approaches needs to be handled. And in this situation, what happened is they were submitting these cases sporadically. Like 1 week we'll get 1 deer, and another week we'll get 1 deer, and those deers were getting to different pathways. And so it was not a unified approach, right? And so when the clinician did not get an answer, he was curious, like, okay, what I'm doing with these deaths, how do I prevent? And so they contacted us, and I said, okay, let me look at all the cases together, right? And so when we sat down together, he and his postdoc and me, that's when we figured out, okay, all these are female, they were pregnant, they're dying, and all the kids, and the males are dying. So I think that needs a collaborative approach between clinicians and diagnosticians. Does that answer?
Yeah. One more extension of this question for do you think that these findings can be interpreted in One Health perspective when applying for any human health? Say for example, you have an outbreak of diseases which could possibly be zoonotic, right? So how this can be incorporated in a kind of One Health framework? Do you think that is it possible for incorporating into the existing system, or how it can be incorporated?
So the existing systems are there. So I don't know much about how the system works here, but when we have a disease that we suspect it's a zoonotic disease, or it's a zoonotic disease, we call it a reportable disease. So what that means is we have to inform the health authorities that, hey, this disease is there in this county or this town. And so what they do is after that is they'll monitor the people or animals around that. So I think that can be translated to human population or One Health approach.
I think even in India, we have I think two type of surveillance regular monitoring. One is called IDSP, I think now it's called IHIP. IHIP. Now similarly they have surveillance system in animals called NADRS, National Animal Disease Reporting System. The problem is many times these as usually goes in silos. Each of the veterinary dispensaries send the reports through their district joint director. It goes to the director, animal husbandry, government applicant, New Delhi. Of course, IDSP also I think from primary health center directly goes. But now I think they included many of the zoonotic diseases under this program. But still there are many spillover events or some infections which are quite new, or new pathogens, or new variants, or new host, or new geography. So these are all quite challenges. How these should be incorporated into this? Unless we have a single unified framework which can collect all these data from both the animal as well as the human. I think it's very difficult to put them in one perspective. Now I think Dr. Chaudhary has been working on in NIE earlier, in ICMR, and definitely he might be very good at epidemiology. And like, how do you think that infectious diseases can be controlled in humans when there is an outbreak of, we always talk about some influenza outbreak, say air influenza. So what kind of strategies, One Health strategies, you suggest when there is a disease which are of zoonotic significance or some infectious nature to human? So,
very relevant question. I have actually worked as a teacher. Maybe while staying at NIE, I have also was part of active surveillance as well. So when, like based on those angles of when I worked, I mean, when I answer to your question, let me take you through something which is little off-bit, not directly related to this, but do you watch cricket, all of you? I think many of us Indians at the end of the day. When you see, I mean, a camera is capturing a video, I mean, looking at from different angles and capturing something. At the end of the day, the decision made by the umpire, by the umpire or somebody else, we all are part of that. It is not someone who is only taking the decision and we are just accepting. You will see that debate going on whether someone is out or not out. It's a very simple way. When we talk about the surveillance system, taking an example of your last point, that surveillance. Surveillance is done for what? Surveillance is done for not just detecting diseases and detecting diseases of whom? IDSP only, as you said, in silos this is working, and the other side in veterinary is also working in silos. Now, that means you are detecting the disease, early detection let's say, and then you are treating. But your question is how we can tackle the disease, or let's say, combat with the disease does not mean that we only treat it. There is other facet of it, how we prevent it, and how we prepare ourselves for detecting the newer diseases that can be both in animal and human, and then we take an action. And in that action, are we involving all stakeholders into our decisions is the question. And there is my example, that example of cricket, that are we involving the community as well into that decision? I'll take you somewhere else, in this context. If you look at the international borders of India, one side Pakistan, where you have desert, one side Nepal, you have free flow of trans-border population migration for whatever reason. Bangladesh, a huge border covering many states actually, and then you have maybe illegal migration. You go to the other side, Myanmar, then you have Rohingya issue. And when such kind of migration happens, especially Rohingya and the Myanmar side, you see how the population stays there, and infections does not, of course, it does not matter where border or where something else administrative borders are. And therefore, is our system prepared enough to tackle such kind of situation, whether you talk about IDSP or something else, let's say animal, surveillance system? The answer is possibly no. Ma'am, you get an example of, let's say, disasters or natural calamities. Such kind of situation, are we also prepared? Possibly not. I'll give you an example of IDSP. IDSP is possibly one of the best, have the best potential, but have tremendous flaws. When we were experiencing the COVID pandemic, that time IDSP did not report for almost 2 years. No report came. All of a sudden, because I used to look at IDSP, we have analyzed many of different types of data. All of a sudden I saw that, okay, it's full. All 2 years it is absolutely full now. Where from this data came? So we need to possibly integrate. Integrate means what? Integrate different departments. For example, today we are talking about Nipah virus, the richest and most infectious disease that came out all of a sudden. Emerging disease. Kerala successfully tackled that. But in other parts of the country, are we ready? Do we learn from others? So integration, learning, all such things are possible potential. How do we do that is the question. And to answer that, yes, we have, we in the sense this hall, I think we have enough potential to integrate and develop evidence how we can build upon the system and tackle those situations effectively.
Yeah, so now most of these speakers, if you tell how we could manage when there is an outbreak. But I think he has, initiated a point where the risk assessment, because that is very critical, because now we are talking about, now you identify, but how you are going to protect. So that is very critical. Of course, the data like IDSP and address might give a hint. But what about climate change? Is there any mechanism by which this risk assessment, these kind of temperature or weather or climate or these kind of change in the environment will lead to an infection or an outbreak? Is there any current system, or what do you think that can we learn from the other surveillance and monitoring system which can help us?
Presently it is not there, but Government of India has recently in this month, the 24th, we had 2 days of seminars were going on with various departments. They are trying to get a uniform checklist with all these departments for the NBCCH.
So, but even if you identify the risk, how it can be managed? It definitely needs an One Health approach. Because if there is a problem in a stream of water or in a sewage which is going out from the city, do you think that only the government, the public health or civic authorities can control? We'll have to see who are the contributors. The contributors could be public sewage or an industry or from farm or from agricultural field. So where do we start? Where do you stop? It is very difficult because IIT Madras, they did a study on the Adaya river. They have a long river. So they did sampling of the entire river originating from and then pass through the city, end up in the Bay of Bengal. They could find many pathogens of different origin. Some of them are very common in agricultural, some of them in farms, some of them are nosocomial hospital resistant pathogen. So it's really very difficult to manage, in fact, not to manage an outbreak, but how to prevent, how to do this risk assessment. So unless we have a One Health approach, it is very difficult to prevent or manage the emerging infectious disease. Dr. Mora, is there what kind of suggestions you tell to public or to the policy makers, especially when you want to have a regular monitoring of animal farms, or even in countries like India where we have say 400 million cattle, which is widespread across India. It's not like the global north where we have highly concentrated farms. Each farm may have say 50,000 animals or 1 lakh animals. But in India, each farmer has 4 to 5 animals. So you find the entire 400 million completely spread across the nation. So it is very difficult unless you find out the risk assessment and prevent it. This is going to be wider throughout the country, not like other countries where each farm, if you close the farm, the infection may not escape. But here, that's not the case. They are living in the next door.
Disease surveillance and reporting, I think, will be better if we educate the people who are working across India. I always tell my students, whenever I'm dealing with an infectious disease, I tell them, you need to identify patterns of this disease. If they're telling you this is going to be a zoonotic disease, right? And so I really harp on those. And in our labs, in our necropsy floor or postmortem floor, all these zoonotic diseases are written in bold and capitals, and it's there, and so they cannot miss it, right? And so I feel like once they know that these things are there and they need to look for these, they're better able to communicate. And so the example is, again, we had a tularemia. Tularemia is a disease that called the Francisella, right? And so when we see this cat suddenly die without any clinical signs, that's the first trigger for a veterinarian and for us to look for it. And if they go and do the postmortem in the field or do the postmortem, it's going to expose a variety of people from when it's getting into the lab, where it's getting discarded. And so that education system needs to make that a point for the students to understand, zoonotic diseases exist and they need to keep an eye on those. One more thing is, Dr. Rudra pointed on that one, is there's no harm in accepting that there is a disease in my province, my block, or my district. Right? Otherwise, if we keep hiding these diseases and not reporting those, it's not going to solve any human problems. Those will still exist.
Exactly. This is what the DG was telling today morning about the healthy villages. So it is not approaching any problem from top down, but from bottom up. See, like as I told you that example of animal diseases in India, where the animals are dispersed throughout India in few numbers, scattered. So how do you manage? We have to empower the rural population. We have to empower the farmers. We have to empower the general public. I was even talking about the antimicrobial resistance. So AMR is a big problem. But how do you manage? All these government rules, policies, regulation will have any effect unless the person who practices, who takes the antibiotic, he himself realizes that I should go to the doctor and get the prescription and get the drug. It's not like going to a medical shop and get the drugs. So similarly, the farmers, the villages, the community has to be empowered to tackle the situation. So One Health, it's not lying only with the bureaucrats. One Health has to go deep down to the farmers, the stakeholders. Because most of the programs, the government run programs, I think may not reach properly because the involvement, the participatory involvement of the stakeholders might be lacking. I am not telling that is one reason, but then we should involve the participant. Say there is a program for villages, without involving the villages, how would you make the program successful? So I think Dr. Chaudhary, you can tell how do the present system to be modified when this kind of an epidemic occurs, and then how do you make the public or the population to participate? Say for example in COVID, that we all learn, it's a new lesson, we never know how to manage. The government completely locked all the towns, they closed, people were restricted, they were even unable to go out. But this is the first, so we were struggling. So when you have such kind of epidemics, what would you suggest as an epidemiologist?
Well, sir, let me put it in this way. During epidemic or before epidemic? As I said, IDSP has a tremendous potential and it has over the time, let's say last 10 to 15 years almost, it is working, and now we are strengthened. IDSP is changed its policy. It is now real-time data capturing, and IHIP gives us that opportunity to understand the data in real-time basis. When we understand that, we also understand which areas are prone to develop what kind of diseases. When we understand that, we actually can prevent those diseases by, yes, of course, empowering the populations about it, empowering media about it. Because I think there is outbreak or health is the, if not the least, emphasized topic or domain for the media, but at least it is ignored. You may or may not like it, but in the hall, wherever it is, you may or may not like it, but that's the fact. And when we understanding that, we also have to understand that government willingness in many places, many states, they have a tendency to suppress. This is a well-known fact. Having said that, now it is lies on the it's a responsibility of the population, and population, when I am saying, it is not about just the community. What do we understand by the community? Is it only those people who are service utilizers? Might not be. The medical officer who is there, the health workers who are working at the grassroots level are also part of the community, and I am talking about all of them. Do they have willingness to report such kind of incidences? If we know about health system, primary healthcare system, we also understand that the healthcare workers are overburdened. Everywhere, everybody will accept that. My understanding or my experience is they do not report, and less reporting. We have to tackle those things, as well as we have to think that how we can incentivize them to prevent and to early identify the outbreak and tackle that appropriately, tackle how to strengthen the primary healthcare system with adequate drugs. Let's say if we are talking about an infection, when we are talking, let's say that take an example of cholera. I think southern Indian region is since ages we are suffering with cholera, and do simple doxycycline, which is the loading dose is 300 milligram available there, and do our health system know about it? There are capacity building is what I am targeting, that they know about it, what to do at what stage. So capacity building, to answer to your question, capacity building and incentivizing about the reporting of cases, and finally empowering the community about the diseases. Let them know about what diseases are that they can suffer with and how to report it. I think those are the simple steps that we can take. It's not easy, but this is how we can do it. Top level, it's piggyback the system ideas your HIP have to openly show how and where the infections are prevailing, so that we can also decide our own how to do that.
So I think now it is apparent that to tackle the emerging infectious diseases, it's not just reporting and taking the response, but also we should have a sustainable monitoring and surveillance and other feedback system, which can probably prevent the later half of the infection. So emerging infectious diseases does not come in an overnight. Of course, few viral infections, but rest of the emerging infectious diseases definitely be identified, or the risk assessment is done properly. So now it is very clear that unless we involve all the stakeholders, it is very difficult to manage any emerging infectious diseases in the days to come. As we all know that, say, more than 60% of the infections come from animals.
I have a question to Dr. Sumita Nair, and since this being part of the government, as somebody who's outside of the government system, it's easy for us to see the flaws, the failures, the problems, and where the government has failed. But being part of the government system, can you give us this perspective of what are the strengths where the government can enable this One Health? Like Dr. Raghu had mentioned in the previous session that we need this architecture or framework of One Health. What are the unique strengths where the government can play an enabler in establishing or enabling, facilitating this kind of a systems? And what do you foresee as the challenges or the barriers or the limitations to where the government can achieve or cannot achieve some of these goals?
So, that first the awareness in the community is very much required for anything as such. When I tell my medical officers or my ASHA workers, when they have to go to the meetings where we have the village health nutrition committee meetings, the sanitation meetings we have, when they have to explain to the people over there regarding any of the disease, because our aim at the primary health is prevention is better than cure, rather than treating it later on. So for that to make them understand at that level, at the community level, see when they come for the meeting, the problems what we face is, why should we come for the meeting? We are ready with our design, everything. Yes, we have to educate the people. We have to make them, give them the awareness. Because nowadays, dengue is very much rampant in the urban area. It has also spread to the rural areas. Maybe chikungunya is rising. But the awareness to the people when we want to go over there, how many people are ready to come over to hear to us? Unless when they face the problem. Yes, one of their child has been suffering with dengue. They have gone to the hospital for the treatment and everything. When they have seen that the problem, the pain they have undergone, yes, they are able to understand. Maybe the examples of such people who can explain to others, yes, we have to sit together in the community. It is not always the government designing the principles to introduce it to the community. In the community, as Dr. Chaudhary has told, it's a demand. The demand from the community should come to us. That comes only when they are aware of it. We are ready with all our principles, rules. We know what to do. If this disease is there, these are the symptoms, this will come. If this disease is not to occur, what should be done in the preventive aspect so that you won't undergo all these problems? We are ready to tell from our side. And at the same time, even our ASHA and the ANM workers, as Dr. Chaudhary has told, IDSP, which is our IHIP, we have the syndromic approach. We know how many kinds of fevers are there in the population. We are taking the data of that, so we know, okay, in this area, this is the problem. In this area, maybe this one is the problem. But when we want to go to the community and explain to them, maybe educating them will take some more patience from our side. So this is the problem which I have. And secondly, there was one more thing of telling, sometimes what happens is our people are not ready to put the facts outside. It is not at all in that way. That is why our IHIP portal has come, which has given us the lenience. Yes, you report whatever you have seen over there, whatever, something deviations, maybe a rash, maybe fever, whatever, maybe vomitings. That syndromic approach, maybe in one area when they are reporting one symptom, the other area is reporting other symptom, we can correlate that symptom and we can come to the conclusion. In the same way, we are having the diagnostic lab, we are having every district we have created our Telangana diagnostic centers, depending upon the requirement. For the basic diseases, we have 150 tests, we are doing it, but maybe like in COVID season we have seen. We wanted special type of tests, we have required. So government is always there to stand for whatever new is coming and whatever is there, but it is the understanding from the community side which requires the teamwork for everyone. It is not alone the health department it has to do. It has to come from the animal health, it has to come from the information education, from the reporters side, and from all together where it is revenue people are working. Only when everybody come together for our health, that one health of ours will be achieved. That is what I wish. Thank you.
Framework which can control everyone. So thank you madam, thank you so much. For now, want of time, I can allow only one quick question. I think as we are getting delayed. So one more question from audience, a quick question. I would appreciate any questions from audience.
Not a question, but I would agree to Telangana diagnostics which the government is doing. It's really impressive. And the hub and spoke model which government has set up for public use with 150 parameters. And indeed, it's a state-of-art technologies. Digital, the data is collected digitally, sent to the citizens digitally. That's one very unique initiative started by Telangana government running from past 5 years across 33 districts, and I can vouch for that. It's quite unique. Thank you for that.
And I think we had a wonderful discussion about these emerging infectious diseases and how to manage using the One Health platform. So this is going to be the only viable and potential option for managing. So unless we work together, unless we unite together, we will fall down for infection. Thank you so much. Thank you so much, Professor Anil.
Which is the third panel that's coming up. I would like to thank the chair as well as the panelists for their excellent points that were made, and that gives us food for thought, and also we'll be inching towards the actual food in a little while. I request the third panel to please keep it within half an hour because they are really behind time. The third panel now. I'm honored to invite our esteemed chair, Professor Ekambaram, Director of Research, PV Narasimha Rao, Telangana Veterinary University, to the stage for the discussion. I would request Dr. Gauri Iyer from IIPH Hyderabad to please give a plant to the chairperson. Thank you. In the meantime, I will Professor Ekambaram is a prominent figure in 96 and a PhD from Sri Venkateswara Veterinary University in 2008. With a 26-year career, Professor Ekambaram has held various roles and is currently serving as the Director of Research at the PV Narasimha Rao Telangana Veterinary University. He has contributed significantly to research, completing 16 projects and authoring 60 papers on animal genetics, breeding and management. A dedicated mentor, he has advised many postgraduate and doctoral students and actively engaged with farmers through 43 TV and radio talks and has received the State Meritorious Teacher Award in 2019. I would now request the chair to please welcome the panelists, and the panel discussion topic is integrating human, animal and environmental health, challenges and opportunities. Over to you, sir.
So good afternoon, and I thank Director IIPH and esteemed dignitaries and invitees from Oklahoma State University and other speakers, participants from various organizations, from my own university, faculty and doctors, postgraduates and other university students. And today this is a really good convergence of different stakeholders or professionals. This is, I feel very happy, and thank Director Anil Kaulji for inviting, and particularly Rajan Saab is the first person I met after seeing this institution. He visited our university also. Now this is a topic integrating human, animal, environment, health, challenges and opportunities. This is a panel topic we are going to be discussed. Now for this, the panel members, first I am inviting Professor Rajan Shukla, Dean, Public Health Practice and Community Engagement, University of Public Health, Hyderabad. Dr. Shukla has over 30 years of experience spreading over emergency, clinical care, health program management and evaluation, teaching and training, health system strengthening, public health surveillance, designing and implementing integrated health programs for strengthening health systems. He is a medical professional turned public health specialist dedicated towards empowering communities and health systems in adapting new scientific evidence to local contexts, using local resources to address the public health challenges, improve population health outcomes and promote social development. He works on reducing inequities by empowering marginalized communities to access high quality healthcare services and providing supportive environment to practice healthy behavior as a means to promote sustainable social development. Thank you, sir. And again, the second panel, Dr. Sridhar Prahalad from UNICEF. He is associated with UNICEF with extensive experience in child health and nutrition disease prevention, and is involved instrumental in developing and implementing health initiatives that improve the lives of vulnerable populations. His work at UNICEF focuses on strengthening healthcare systems, especially in underserved regions, to ensure equitable access to health services for all. He has a keen interest in the One Health approach, emphasizing the interconnectedness of human, animal, environmental health to address broader public health challenges. His contribution to policy making, health, education, and community-based programs underscores his commitment to sustainable health solutions and building resilient communities. I welcome you, sir. And the third panelist, Dr. Nirupama. He is a dedicated professional specializing in research, teaching, and administration with a focus on non-communicable diseases and mental health among adolescents. She has made significant strides in understanding and improving health outcomes in this demographic. Her interest lies in navigating various aspects of public health, including health systems, strengthening telemedicine, occupational health, and healthcare utilization. And driven by her passion for teaching, she aims to mold future public health enthusiasts while striving to make a lasting impact through her research endeavors. With a commitment to research excellence and a desire to create positive change, she is poised to continue her impactful contribution to the field of public health. Welcome you, madam. And now, see, this is very important in a part of One Health aspect. We know the One Health interconnectedness of animal, human, and environment, where the first two components are going to be shared. And how the integration between these three components, you know, they are working in different directions. We see from governance, administration, institutional, and at implementation level, and receiver end, total diverse. As an animal health worker, as a human health worker, as an environmental worker or scientist, you know, each and everybody objectives and roles, responsibilities different. If you see at the grass level, everybody can work, all people can work in a same village, but they never sit across table and discuss the problem and outcomes of their works. Then it is we are talking about One Health, but it is very, very important. After COVID, we learned many lessons from COVID, starting from lifestyles to ethics, social ethics, how to live in a society. It taught a lesson. Money is not a matter that by COVID incidents we learned. Top to bottom, all officers including police also involved in COVID. Why? Because that is across the sectors. Now the same spirit, we have to work here, we have to prepare to face preparedness for emerging diseases. Diseases will come. So there are emerging diseases. Every day, everywhere, here and there across the globe. Diseases are emerging, but not detecting. Where developed countries, advanced countries are detecting, diagnosing, preventing and responding to the risk, but not in poor countries, underdeveloped countries like India, even in developing countries also. There are several reasons. It is a continuous process. We have to live in a given environment. The planet is the same, we cannot expand. The land is the same. Animal has to live, human has to live, plant has to grow and produce, and we have to continue. This is all a fixed work. See how to integrate. Only we have to change our actions, activities. Whether animal scientists or human scientists or any other scientist, social scientist or environmental worker. Because we have to keep ready and face those problems. Then how to minimize, how to control and regulate, that we have to develop as a part of One Health concept. Now, as for the animal health, how to integrate animal health and human health and environmental health. Animal and human sharing the same environment. We will study in our course. Environment plays a vital role in development of a genotype, in production of a genotype. If animal is there, unless until cooperative environment, animal may not produce meat, milk, egg, even birds also. So the environment plays vital role here. If you regulate, if you control, if you keep healthy environment, ecosystem, then animal is safe, human is safe. This is mine. We have to focus main on environment, then animal, and only human health in One Health approach. Because why I am telling, nearly 60% of pathogens causing diseases to human or animal origin only. Then what about 40%? If you control and keep animal healthy, the 60% of pathogens are going to be controlled, prevented. Our food also, safe food we can produce. Food system we can produce, regulate. Then other even 70% of emerging diseases are going to originate from animal, wild animals. So in coming years, scientists are saying all emerging diseases are going to be come from animals, wild animals, reserve animals, generally from environment side. So that's why we have to focus, main emphasis on environmental health. That is, as part of our Prime Minister's recently, as a part of G20 Summit, India Presidency, the theme is One Planet, One Family, One Future. It is you can take it as a One Health spirit. So as a family means at multi-level, multi-stakeholders, multi-institutional, multi-sectoral. We have to keep it as a family. That means we have to unite, just like a family members. Then we can tackle any risk, we can respond any risk. Now that's why animal health is a main concern. As part of India, you see our livestock is dominated in the world is a diversity. Animal, domestic animal biodiversity. We have 212 registered breeds, 53 cattle breeds, 20 buffalo breeds, 40
type of data are required. That has to come from experts sitting in this room. And then she can work on the data governance, standardization of data, etc., etc. But all this will happen only when we first start thinking in that manner, the scientific approach, the comprehensive, holistic scientific approach, and then interacting and applying that across the field. So that is, to me, how we should reach out to One Health. The second thing that I feel, and I've been listening to that right from the morning when DG said, he said community engagement. But if you look at, even we have strengthened our IDSP, and IHIP is an excellent upgrade from the previous IDSP. Okay, but where is the community's involvement? Why can't we involve community into surveillance? And that surveillance need not only be for human health, it could be for animal health, it could be for any unusual event. So this is a concept called as event-based surveillance. We primarily rely on indicator-based surveillance, but we should promote event-based surveillance, and that is where again engaging community would be very important. So I will stop because I know there is paucity of time. So I will stop here and yes, back to you.
Thank you. IIPH for organizing this wonderful symposium, and also want to thank Professor Kaul, Dr. Rajan and Shailaja for giving this opportunity for UNICEF to be part of this panel. So to just break the monotony, I'm just using few slides because I prepared it yesterday night. I just want to show it to so I'm seeing many of the people are hungry in the meeting, so I think this will just bring your attention here. And as UNICEF, my priority here is to bring children at the center of the discussion of this entire One Health, and that is what I'll try to make that attempt in next few slides quickly. Healthy Environments for Healthy Children is a new division formed within UNICEF in UNICEF headquarters in New York in 2022 last quarter. So it's just a 2-year-old program for UNICEF. And where this mandate comes for UNICEF comes from this remarkable or a phenomenal resolution passed by UN, which is Convention of Child Rights in 1989, which talk about the child rights, that every child has a right for good health, for good food and good nutrition, good learning opportunities, and an environment where there is no child abuse or domestic violence. But along with that, they also say that every child needs clean and safe environment to live in. So that is where, as UNICEF flag bearer of child rights, this mandate comes for UNICEF. Otherwise, WHO is the lead UN agency for One Health. So UNICEF did this Children's Climate Risk Index, and it has two pillars. It sees the exposure and sees also the vulnerability for climate change in every country. And as per this index, they have categorized the countries, and if you see, India is categorized under extremely high risk. And if you see the total estimation, it's almost approximately 1 billion children who are living in this high risk countries for climate change. To give few numbers, 820 million children are currently exposed. It's not a future estimate. Currently exposed for heat waves. There are almost 600 million children who are exposed for vector-borne diseases globally. And if you see almost 2 billion children, it is almost 90% of the world's child population are exposed to air pollution. Similarly, 815 million children, almost 1/3, 30% of all children in the world have high blood lead levels. I'll come to this point. And children are the most vulnerable because of their physiology, because they are young and vulnerable. their alveoli are not as mature as adults, so they are more prone for air pollution. They have a permeable blood-brain barrier, so they are more prone for toxic metals and toxic chemicals. So their consumption, their digestive capacity is 3 to 4 times than the adults. So if they have toxic metals like lead poisoning, they can absorb 4 to 5 times higher than the adults, so they are vulnerable. To come to specific impact of climate change, I'll just highlight few points. If you see from extreme heat point of view, stillbirth and preterm birth can increase by 5% with every 1 degree Celsius rise in temperature. Droughts, you know, the impact of malnutrition or droughts on the malnutrition leading to food insecurity and low birth weight. Wildfires, if you see each 1 microgram per cubic meter increment in particulate matter 2.5 emanating from these wildfires is associated with 2.3% increase in child mortality. They estimate that 26% of the under 5 mortality can be reversed. The achievement whatever we have in SDGs over the last 3 decades can be reversed if we don't address the climate change risks. Floods and storms, if you see this, infants living in flood-prone area have 8 times higher chance of dying compared to a child who is not living in flood-prone areas. Air pollution, globally, among adults, air pollution is now the second highest risk factor for death after hypertension, that is high blood pressure. Similarly, for children, it is second next to malnutrition. So globally, they estimate that 709,000 children deaths under 5 children are directly related to air pollution, and almost 2 million preterm births are annually attributed because of the air pollution. Ecosystem changes, we are talking about animal health and human health. WHO has documented 10-fold surge in the incidence of dengue. So from 500,000, it is now 5.2 million dengue cases. And UNICEF categorizes this entire climate change and human health risk factors or the approaches into 5 categories, asking every country to prioritize these interventions on toxic metals, especially the lead, toxic chemicals, especially the pesticides, hazardous waste, particularly biomedical waste and e-waste, environmental risk, particularly the air pollution, climate change, particularly the extreme weather conditions, the heat stress. The current NPCCHH program from the ministry focuses more only on this and one part of this. But there is a discussions happening at the ministry level, at the NCPC and NPCCHH level to at least start including lead into the program and then go with other programs. If you see the risks, the loss of dialysis in the under 20 years children, irrespective of the economic status of the country, they are all impacted by air pollution and lead pollution. So no country can say they are immune to the impact of environmental health and climate change. Last 2 slides, 2 points on bringing the importance of lead poisoning. You saw the global data, 30% of the world's children are impacted with lead. This is the one data from India. NITI Aayog did this study. In 23 states, they found the average blood levels is more than the permissible limits of 5 microgram per deciliter. And if you see our own study, which was done in 10 cities in India, where the KGMC Lucknow was the principal investigator and Manipal was one of the co-investigators. They did it 10 cities. Randomly they checked the lead levels in blood among school children, and they were all from urban schools. You see the average was 8.8, far above the permissible limit, and you see Manipal 30.6 is the average, the lead levels of blood. One study in Bihar, 90% of children and 80% of pregnant women among their sample size reported the lead levels in the blood higher than the permissible limit of 5 microgram per deciliter.
Recording in progress.
So I will conclude my talk by saying that the children's environment health deserves highest priority in the world, in every country, in every state. Thank you.
I was put in this panel, I was told that I have to bring in the non-expert opinion. That is why I was put in this panel. So there are few that we want them to focus on. So whatever we are trying to give to the audience or whatever is the group that we are going to cater to, we have to keep it very simple. We should not use like high funda words and detect, we are distracting them from the point. Now they are, instead of googling what is AMR or what is One Health, they are now googling what do you mean by cybers. So the whole point of the symposium is lost in that sense. So this is an example which happened here today, so I thought I'll start with that. And coming to my topics, I was asked to talk about opportunities and challenges. There are a lot. See, you go and Google it will tell you, ChatGPT will take you to opportunities and challenges. You don't want me to talk about that. But then there are certain sectors which we have missed out, which I want to bring it here. One is the tourism sector. So tourism sector plays a very important role because they are part of challenge and opportunity. Challenge, why? Because as Dr. Chaudhary was mentioning, there is a lot of, we are talking about migration. What about tourism? Tourism also brings in a lot of infections for that matter, or any new health condition, or any new, there's something known as acculturation when we study, I did community medicine, so there's something we study known as acculturation, where you cross-mix cultures. Anyone from IAPH will understand that very quickly because we are all from different parts of India and we celebrate all festivals in IAPH. So it's not just the festivals. I am traveling from my home, I am bringing some disease from my state. Rajan sir is traveling from his state, he is bringing some disease from his state. So that is something that we need to work to, and in that tourism plays a very important role. And there is a very important aspect of surveillance and monitoring which we are missing out, which is biomonitoring. We can do biomonitoring using sentinel species monitoring. This is something which we have, I will not say that we have not explored it, but in India, in One Health, this is a very less explored area, and this is actually a very good trigger when this is not for the general public, because we are talking in a scientific community and bringing this point up. So sentinel species surveillance can be a plant or an animal which is particularly present in an area, and the absence of that plant or species from that area will directly be an early ecological indicator to a health threat that is going to happen. This is a very big point that we can tap into, because from time immemorial we have been told that animals know before humans that what is going to happen. If animals are fleeing a place, you should flee first. Yes? So these are things that we need to tap into. And talking about opportunities, a big thing which is in front of us is social media. We have to talk about social media. We cannot have a conversation of One Health or any health issue for that matter without talking about social media. There's a lot of wrong information being given. We only talk about the negativity of social media. But what about the positive things? Many of the people in this audience came to know about the symposium because of social media. Social media can be tapped for good things as well. When we are talking about health literacy in a country like India, it is very, very difficult to go house to house and tell people this is One Health, this is what you do. You put a WhatsApp video, it will spread like fire. So these are the things, there are what I have tried to understand in my last 2 days of reading about One Health opportunities and challenges, how to find opportunities in the challenges which are being discussed. One major challenge which is being discussed is lack of data. There is data available independently. These data do not talk to each other. How do we make them talk to each other is a very big conversation which is going on not just in India but globally. There are a lot of things. I think this symposium for that one is a place where we can actually make in systems where these data actually talk to each other. So that is my understanding in the last 2 days of reading of One Health. I will stop with a quote from Oprah Winfrey: challenges are gifts which will make us want to search for a new center of gravity. Do not fight them, find a new way to stand. Thank you.
Thank you, madam. And types of integrations. What is the desired framework? These things before going to this topic. Now I want to give an example. This is a veterinary profession and medical profession, how they are working in a field. Because if you see, I am quoting on a disease, that is see where a disease, anthrax. You know that anthrax is a zoonotic disease. Anthrax.
I request that the students be guided, students from IIPH as well as students who have come from outside, to please be guided by our IIPH staff, Madhavi please, because there is lunch which is here as well as in the other place because of shortage of space in the room here. So please follow Madhavi. I also request Professor Anil Paul to present a memento to our chairs and to the external panelists, and I would like to call upon the stage Professor Yogeshwari has left. Professor Rudra Gowda.
Thank you. Yes, madam. 1 second. Thank you. 1 second. Thank you. Thank you. Yeah.
We'll move to the next panel discussion, which is on food security and safety, bridging human and animal health. And for this, I would like to invite our next chair, Dr. Nandakishore Kannuri. I'm honored to introduce Professor Nandakishore Kannuri from the University of Hyderabad, who is Associate Professor there, to moderate the discussion. Professor Nandakishore Kannuri, fondly known as Nandu, Dr. Nandu in this institute, is a distinguished faculty member at the University of Hyderabad, specializing in public health, social medicine, and community health. His work emphasizes the importance of social determinants of health, health equity, and the integration of indigenous health practices. Dr. Nandu's research often intersects. I would now request Dr. Sirshendu to please come up to the stage to give a plant to Dr. Nandu. Thank you.
And to talk a few points about it, and then I'll call upon the esteemed speakers for the panel. So when you talk about food security, where did it start for us? Because the world was very food insecure a few years ago, a few decades ago, and the food insecurity is a serious and immediate concern for all of us, and then one of the major drivers for food insecurity was the overpopulation to begin with. But eventually, the conflicts, animal, plant, and human diseases, climate change, biodiversity, loss of biodiversity, depletion of resources, and environmental climate change is a big factor. So all of it led to food insecurities. And then, when you look at the rising population, we were about 2 billion around in 1920s, and eventually we grew up to 8 to 9 billion in 2024. So the challenges are many. Then food insecurity, we try to address this food insecurity with interventions such as Green Revolution. And Green Revolution was magical, we all know, it put us out of the food insecurity. It made food accessible, affordable and available, across the world. But if you look at the Indian context, we try and come to the success of Green Revolution and started plateauing around 1960s, but many revolutions followed in food security. You have, of different shapes and different colors. You have had round revolution for potatoes, yellow revolution for oil seeds, golden fiber for jute, and then golden for honey and apiary, and then we had silver fiber for cotton. All of these are food security related and livelihoods related. But if you look at the pink, blue, white and silver, we have pink for the meat, blue for, any guesses? Fish, yeah. And then we have white for milk, we have known for milk, and then silver in animal husbandry. But these complex issues around food security and the exploitation, unhindered exploitation of all these, the pursuit of putting humans in center, very anthropocentric design of this so-called development, is something which one has to really critically look at in the context of One Health. How do we locate us as human beings, and we assume that everything around is for us to consume and develop. So do we really look at that way, or should we really go beyond and try and see what is it beyond this evident exploitative way of looking at other living beings, including plants and animals. So that's the context. And if you come back to Indian context, food security is highly vulnerable because we largely depended on few species, either animals or plants. We have moved away from indigenous crops, indigenous animals. Sir was talking about the native breeds of cattle and poultry. We moved on in the pursuit of exponential growth to large-scale monocropping and large-scale, output, for example, poultry. So if you try and look at all these things, and these revolutions were slowly plateauing, and suddenly COVID happened. And then things all changed for us. Yes or no? Okay, thank you. I just trying to keep you awake. Lunch was very sumptuous and tasty. So when you look at these, we suddenly started realizing that, okay, we have to connect the dots, humans, animals, environments and plants, and then we started to talk about animal sort of health, plant health, slightly lesser in scale, but environment health is slightly bigger. If you look at the silos, what we were talking, Nirupama made them famous now. So when we have these definitions, and if you look at One Health, there's a collaborative, multi-sectoral, transdisciplinary and holistic. And that's where I think Professor Malayer's talk in the morning was very interesting, and he was very happy and glad to be here today because somebody spoke about social sciences. And being an anthropologist, it touches someone. So he's glad that people talk about social sciences because ultimately that is what it is essential. Solutions are there, but are people, is there an uptake of solutions? Is there uptake of whatever we as specialists are talking, are they reaching, is the concern. So, that is where it brings to an exciting sort of a panel. We have wonderful speakers, friends, part of speakers. Professor Ekamaram Garu, who was very eloquent in the morning. Sir, I invite you to come onto the stage. Dr. Gauri Iyer, he's doesn't need much further introduction, but he's there representing the animal health. We have Dr. Gauri from human health, but from a behavioral sciences perspective, and we have Dr. J.K. Lakshmi, who is an ardent, holistic health proponent, and her core strength has been health promotion. So, I won't wait much time, we all know each other here. Trying to make poultry as an important sort of an industry. And Telangana and erstwhile Andhra was known to be egg bowl of India. So in that context, sir, I would really want your inputs to begin with on why do we think to be cautious when we are talking about animal protein in the context of poultry. And we know that growth promoters, sir also was talking in the morning, colchicine is very commonly used, high-end antibiotics to promote growth. So we'll begin with your thoughts on that, sir. And also the subsequent question would be in terms of how do we integrate ideas of, because you're also heading research, how the research happening in veterinary science could be translated to the common people. And again, take on from what Nilpama said, how do we please look at me also sometime, not on the phone. So I was trying to bring her attention in terms of how do you translate these messages to people who are dependent on the poultry industry as their livelihoods and for security or food safety and security. We'll start with it.
Good afternoon. Now this is a good question. And livelihood in rural area. Earlier, the poultry is small and marginal farmers and small villages also is there. The production system is totally changed now. It is total corporatized. Even in rural area, poultry farms also is in the hands of 2-3 players. Venkateshwara, Suguna, and other units of them. Total industry. Right from leading to and processing and delivery of end products. Sector is segmented like that and total in the hands of it. The system is integrated type. The poultry industry total. These 3 players, they supply the chip, they supply the feed, they supply the medicine, they supply the services, and they buy back the birds at as per their market price. The owner has to provide only shelter and produce. This is the system is going on. Now see why the AP state and now even Telangana, this state is called as egg basket of India. The poultry, father of Indian poultry industry, B.V. Rao, Venkateshwara. Once upon he was a worker and of our university, the poultry department here in College of Veterinary Science, Hyderabad. That is the main center for this development and changes. Now see, one is the egg, another is the chicken, meat production. Earlier the meat, the egg production, just we want to understand how pressure is building on poultry production. That is intensive farming now. Ultra farming also is there now. Modernized, totally on par with developed countries, the poultry sector. Now there is a lot of pressure. That's why avian influenza, emerging diseases are coming from poultry side only. Why it is coming? Because we have only few varieties. We have now, as of now, in India, 19 registered poultry breeds as per the National Bureau of Animal Genetic and Resources. There are different agroclimatic conditions, different native birds are there. That is an integral part of our lifestyle as a backyard poultry. That was the traditional system and scavenging system. Zero input and producing free eggs and meat, thus a tasty flavored meat. That was the system out there. Because of what happened on commercial and business scale, we got imported, widely gone, and produced, developed and egg production once upon 180, 200 eggs. Now today, 328 to 333 eggs they are producing. The capacity has increased by means of different breeding methods, selective breeding, cross breeding, different ways and means the system has developed by means of research R&D in the animal feed, in the animal, poultry breeding and poultry health also. Because different varieties also developed under broiler system, private industries. This 333 egg means there is a biological limit. Still people are working how to increase it. Now it is a plateau we reach. Then what else? Egg cost has increased. Earlier 1 rupees egg. Now it is 6 rupees, 8 rupees, and some seasonal variation also is there. Keeping quality. Now how to overcome that, reduce the cost, market players. Reduce the feed cost. How to reduce the feed cost? In any livestock farm sector, the cost of economics, the main determinant is the feed cost. 60 to 65% of the cost is only feed. Again, within feed, in poultry, maize grain is a dominant, around 45% feed cost. Soya bean 60 rupees kg, maize is 30 rupees kg. There is a competition to even. That's why people are trying for egg production. Somehow it is stable now. The other side, meat, broiler chicken, that is very different. Robust technologies, breeding programs, under research. Now the broiler bird, 38 to 42 days, they are able to grow up to 2 kg body weight. It's a matter of 38 days. See the days and body weight. The faster growth in a shorter period, more profit. That is the industry, is a target. How to get that body weight? By growth promoters, by earlier years back, for the sake of prevention of diseases. So, antibiotics also, permission level they have added in the feed additive, as a feed additive. Now it is not there. So thereby, they increase the body weight. But what happened now? 1.4 to 1.7 kg feed, that is the FCR, feed conversion ratio. For 1 kg of chicken production, the body is consuming 1.4 to 1.7 kg feed. Now, present broiler chicken rate is 220 rupees kg. That's a blessed one. And live weight is 160 rupees, 150 rupees. There is a seasonal variation is there. Sometimes 90 rupees. During COVID period, 1 rupee, 1 bird. That is several things due to avian influenza. Now that's why there is there. How to overcome that one? Because the system is intensive system. Now almost biological limit we reach. As of India now, 530 plus millions of commercial chicken is there. And 300 plus millions of backyard poultry also is there. Because the trend is changing. People are consuming, preferring country chicken, desi birds. That's why universities have developed their own varieties. Country to thrive on zero input and scavenging system. In that line, our university has developed one Rajashree dual purpose poultry variety backyard and can able to produce 160 to 180 eggs and up to 1.8 kg body weight. This is suitable for zero input, that is the scavenging system, and a backyard system. Alternate. People are going for desi chicken, the market is gaining. That's why our birds are almost 800 plus million chicken is there in India. Now here there is a pressure, growth is reached. Now because of pressure, what happened? New diseases, the migrated bird effect, and within the population, vulnerability is there. The eye susceptibility has increased, and because of that reason, the H5N1 avian influenza.
So I'll ask you to pause there. I'll come back to that. Because that's an interesting and quite a comprehensive overview on the poultry industry, because that's one of the most popularly touted response to food security, especially in terms of protein security for the large masses. We have problems. I'll come back to what
Just one point.
Yes.
Now here another thing, for as a healthy person, ICMR recommended 180 eggs per year. Now as of now, India is producing 138 billion eggs. The per capita availability only 101 eggs per year. Per capita. There is a huge gap, 180 to 101 eggs. There's still lot of demand is there. And the same meat also, 9.7 million tons of meat we are producing. The per capita is only 7 kgs per year. 7 kgs per year. But the recommended ICMR recommended is 11 kgs. There is a lot of gap between recommended and per capita consumption. That's why the demand is there.
Yes. Now I would call upon Dr. Gavin Iyer. Knowing your work around COVID and also in terms of your research on vaccine hesitancy among the rural populations and and also in terms of the rural populations and healthcare professionals, I'd like to link, if you can, to try and see, can we connect vaccine hesitancy among the humans and vaccine hesitancy among the people who are raising livestock? That is one question to begin with, because I think that's where a lot of One Health issues can be looked at. Prevention, as a preventive perspective, how do we integrate the research and development around human and animal vaccines? And is there a way to connect these two sectors and silos again to continue?
Thank you, Nandu. I actually echo Dr. Yogeshwari's. I feel like a fish out of water in this thing where I come from a very behavioral human health perspective. So thank you for linking it to my work, because this is completely unfamiliar to me. I think one of the things we can kind of universality, especially across human behaviors, that you can take across this animal health or human health, is it's humans making the decisions across both sectors, and the drivers, they're both market drivers for vaccination in animal health and social and behavioral drivers across both for human vaccination and animal vaccination. There are some commonalities that I could probably touch upon, and some I might ask for clarification, because I'm not familiar with the coverage of animal vaccination in India. Is it considered good at this point, or is it, before I continue on, I just wanted a clarification on what is the current animal vaccination coverage?
Coverage is there. The disease surveillance and reporting and preventive measures are there. But the coverage for certain diseases, especially the FMD, foot and mouth disease, hemorrhagic septicemia, and in case of these sheep and goat, heterotaxemia, and now recently that is blue tongue disease, that also newly introduced vaccination. But the coverage is there as per this total vaccination being done by Government of India first and state government through the department is there.
Is there like a 70% you expect? Like, is there pockets? What is the
Yeah,
lowest and the highest?
but that is there nearly, I think 60 to 70% population will cover, because there is sometimes farmers and between the gap because of non-availability and bringing up the animals to the site of vaccination. There's a logistical arrangements are there.
Thank you for that clarification, because I think that's the gap in my knowledge is I don't know the animal vaccination coverage. So I think when we talk about some of the behavioral drivers that impact animal vaccination, I think as Dr. Ekambaram has also highlighted, it is the cost, the accessibility, and I think there is probably one variable which probably is unique to livestock and animal health is probably the commercial value of the livestock probably drives the vaccination coverage in animal health, which may not be the case which is there for human vaccination. And of course, knowledge and use. I think there were some studies that I was looking at when we were looking at livestock. There is, I think Dr. Rajan also touched upon it, the diffusion of innovation or dissemination of knowledge transfer from experts to farmers is actually, the gap is huge. And that's where I think people from public health, animal health, social scientists can actually have a role to play of knowledge dissemination and improving the education and awareness of bridging this gap where the scientists seem to know the importance of vaccination. The scientists understand, I think, across different livestock, whether it is large cattle versus poultry, both from an economic sustainability, environmental sustainability, and even a social sustainability point of view, why vaccination is important. But I think that gap probably persists for a bunch of these reasons about risk perception and cost and the commercial value. But one of the things I wanted to touch upon, and I think Nandu in his introduction talked about, Shailaja mentioned, we have also lost touch. Indigenous knowledge systems actually do respect this overuse of natural resources and know how to draw limits. And I think if you look at the US Native American population, or here also in India, we've kind of, with Western modern understanding of siloed approaches of specialization to sciences, this respecting boundaries of limits of how much to use and consume and how much to limit is, I think, one of the critical factors that has to change in our understanding and approach to how we, reaching the goals of One Health and sustainability.
Yeah, I think that actually touches upon and segues into my next question to Dr. J.K. Environmental, sensitive, conscious, and also wants to promote environmental, holistic outlook towards, health. And her specialization and doctoral training is on health profession. So I want to bring, taking on from what Gauri and Dr. Ekambaram has mentioned, now I think we look like we are secure in terms of food. Though there are certain gaps, but looks like we are secure. So, in a way, then how do you reconcile the existing, approaches towards human health, animal health, plant health? Do you have some sort of overarching sort of a perspective on that? And also, to continue that, would you also comment on the food safety aspect of it now? Now that we are secure, now we are talking about meat being contaminated, leaves being contaminated. Till we did not have enough trees, we never complained. So I'm trying to look at it that way. Do we have enough now so that we are complaining what is it? Is it lead or copper or gold? If you say gold, everybody will eat green vegetables. So we'll begin with that.
Yeah, thank you. I'll speak a little bit about health promotion, my favorite topic. If you jerk me out of sleep, I would be saying the same things. So two messages from just the term health promotion and the term One Health. there are two calls to action or two positive messages and two cautions that I get. And one message is one of holism, of the imperative to take a holistic view of health. I'll talk a little bit more about that. And the other is to take a life course approach. So health is in the first place not to be narrowly conceptualized as absence of disease. There's much more to it. There are many positive aspects to it, not just an absence of something negative. And the life course approach, because it's not like a one-shot thing. Okay, you're healthy, not healthy, and that's it, like done. There are consequences, there are actions and consequences, short-term, medium-term, long-term, and this that we should avoid getting so enamored. I mean, we shouldn't be following trends so blindly that we dismiss, again, the thing that everyone has spoken about, but I will continue to speak about because I feel so strongly about it. We need to examine all practices. Just because something is traditional to us doesn't mean it's useless or primitive or regressive. There is value in many old practices and there's value in many new practices. So we should be wary of dismissing wholesale, either old or new practices, and pick and choose better. About food, as you said, food security is our big concern, and food safety. That's in the title of the panel, so we can't avoid talking about those. And I want to add one more S to this, food S, and the S that I want to add is food sovereignty. That is the ability to have a preference and to exercise a preference on the foods that you consume. And that also, as you can see, makes it important for the powers that be to make things available, to make things affordable, to make things accessible. So with food security, I mean, our concerns with food in order would be first quantity, like you need enough food. And to translate it into nutrition terms, it might be as calories. And there I think we do have enough. When I say we, I mean in the aggregate. There are still people who are literally going hungry, and then there are people who have what is called hidden hunger. So they may not be missing calories, but they are missing nutrients. So we do have enough overall. Let me use the terms or the words that no less than Gandhiji used. We have enough for every man's need, not for every man's greed. So we do have enough, and when I say man, of course, I'm hoping that man embraces all of humankind. Okay, so quantity, calories, and the next step is composition. So you have to have the nutrients that you require. We are not as self-sufficient as we should be in that regard, but we are there, and people who have the means and the agency also have some kind of a good grip on composition. But there's more. There's ensuring absorption and how these nutrients or these food items are put together, made available, consumed, and so on. So there are many gaps in those places. And then safety, which you asked me to talk about. So food is not always safe, and here again I'm going to come back to One Health. The world has become smaller in many ways, but it continues to be its size and larger in many other ways. What I mean is, we have excellent communication systems, and we know the trend that is taking place at our antipode immediately, and we are keen to jump on the bandwagon of consuming quinoa and consuming chia seeds and those kinds of things, which may be nutrient, I mean, no confusion about that. But for quinoa to reach here and come into my plate, it's very, very expensive. It's very expensive in ecological terms, and the many dangers that many speakers spoke about in the morning. And I'm thinking, we've been giving plants to all our guests, and the guests will take these plants, and the international guests will not be able to take these plants, which is a good thing. Because with these plants, there are some free gifts, as we call them, that we are giving those guests, and we're giving them a few pests, and we're giving them quite a few other things along with these, which have...
They gave us also.
Yeah, so we've done that. So we are free to move these pests and invasive species around here, but at least they will not. So we need to think about many of those things. So there are foodborne illnesses, infections we talked about already pre-lunch, but also other kinds of conditions that are not infections. And they have also been talked about. There's lead, and there are all those contaminants of different kinds. And as Professor Ekaman talked about, there's Actually, I'm confusing the various veterinary experts. But you spoke about hormones and antibiotics and so on in the. So there are many foods that are giving us various other things. So I may develop a hormonal disorder or just experience all kinds of untold stress. And it is actually related to an animal food. I may be consuming honey, which I don't even think of as an animal food. But there are many such things. So there are infections and non-infectious contaminant kinds of things that come in, biological and chemical contaminants. And this safety has a lot to do with the travel that the food has to make. So I think that some ways for us to keep ourselves a little safer will be to be slightly old-fashioned, but not terribly old-fashioned, because if we really become extremely old-fashioned, we have no agriculture here. Then we are completely at sea. So we need to be somewhat old-fashioned and be local, be organic, those kinds of things, because we have solutions. We have the most efficient solutions with us, and if we don't have to look outside for extremely strong chemicals that will wipe out what we don't want as well as what we want. So we have many solutions of that kind that we need to be looking for. So local, organic, minimally processed, those are the ways to go to achieve this kind of health promotion. I do want to say that animals and plants are the living world. You spoke about how we have an anthropocentric view. We definitely do. And we need to school ourselves into a far more humility than we currently possess.
I'll stop you there. It's hard to stop myself. You're quite passionate about it.
I'm sure Sharanya was waving madly at me, but I wasn't looking.
So that was wonderful, JK. You know, that actually connects what we started on, trying to talk about food security and connecting, taking it forward. But are we really food secure is a question you raised, and that's, I think, for us all to ponder in terms of how inequitable food security is. And also, Dr. Ekambaram also emphasized the fact that there is still a gap, though we made leaps and bounds of progress in terms of the quantum of the food safety efforts, but we still are falling short, and unfortunately it's inequitable. And Gauri has highlighted the ways to try and think. So on that point, I was trying to also connect and leave the last words to Dr. Ekambaram to try and see how we are here. You know, morning, you can switch off the morning we were talking that this is a One Health lane. You know, this lane has plant, animal, human health and rural development institute all together. So, how do you think then is for us to come together and collaborate? Does the existing structures facilitate these cross-learning and cross-sharing? And also, should there be a sort of a research and development where we all come together? Would IFH be a avenue, or would Oklahoma facilitate certain avenues, or even PV Narasimha Rao Institute for things? So where do we really go on from here is my question, typically if you look at it.
Yeah, this is collaboration. That's the main principle of One Health. And animal traceability also is there now. That is very important. If anything happened in remote area, a particular category of animal, that was also vaccinated, unvaccinated, as per the owner, unique number is there. That is thereby they are identifying and tracing. Our system is there. Even State Department of Animal Husbandry, they are maintaining records at village level. How many animals are there? Who are the owners? How many animals they have vaccinated? Now the system is they have to upload online immediately that vaccination.
No, vaccination I understand.
Yeah.
I'm talking about antibiotic use.
Antibiotic use also, AMR also, the highest percentage of drug is used to control mastitis disease in India. There is a big problem in India. Mastitis disease they are using. Then followed by reproductive disorders in animal repeat breeding.
Vaccine to prevent mastitis?
No, it is not there, but it is there are multi factors are responsible for mastitis the allergic mastitis and a lot of irritation is there. That's why is there. The other antibiotics in poultry, that is there. But that work is going on in the research institute. Even our faculty here is there. Here they are attending now. They are working on.
To reduce use of antibiotics.
Yes, antibiotics and some herbal products and those things also. They are alternative medicine. That also increasing in lifestyle.
Can I quickly
Yes,
sir, please. So regarding the antibiotics,
yes.
everybody what?
No, please.
Veterinarians use the same class of antibiotics.
As you, right.
Yes, there's no difference. The factor is the cost. Cost of veterinary medicine is higher than the products. So even as a practitioner, I prefer to buy a tetracycline or even Polvinase, even for a fluoxetine or ciprofloxacin, of a human practice, because that is cheaper. Sheer volume. And the vaccination, there is no control of use of antibiotics. And as rightly pointed out, there are certain livestock diseases which are economically important, like mastitis. Yes, once the water is affected, the animal doesn't gain weight. That's it. So antibiotics are used both parenterally, orally, as well sometimes in feed. That is common, and it's more so in commercial animals. So whatever animal, food animals raised for commercial, the use of antibiotics directly or indirectly is not good.
One more thing, in animal sector, breeding system also is developing for breeding with animal disease resistance. That's also a lot of research in small ruminants and the disease there. The animals which are resistant to particular diseases, parasitic infestation, they are breeding. So that kind of thing is there. Keep and go. And that is one of the
Percentage of use in the US, like 70%.
Sorry. Yeah. So just to conclude, I think, hope we didn't scare you of eating eggs, chicken and milk. So I think, yeah. So I think, but the point is, I think what Dr. Ekam was emphasizing in terms of creating platforms for all of us to collectively think and then eventually bring community on board for taking forward the conversations around One Health. And I think probably having a representation of plant health probably also should be thought of next time. I think that's one gap we working hard. I think thank you the panel for wonderful conversations, and we could
Thank you for allowing me to ask questions.
yeah, I think we will continue the conversations after.
Wonderful discussion that we had. I realized that they were all very articulate panelists, and so the discussion can continue. I'm sure it will beyond the confines of those sofas. So we will now move on to the next part of the program, but before we do, I would like to introduce our very special guest here, Ajay Sani sir. I'll just do a 1-minute introduction because we have a more detailed introduction coming up later. Ajay Sani sir was the Secretary, Ministry of Electronics and Information Technology, Government of India. He being a very illustrious IAS officer. He was also Principal Secretary, Health, Medical and Family Welfare in the Government of Andhra Pradesh earlier. I will talk more about sir once this particular panel also gets over, because we'll have a more formal introduction to him. But thank you so much for joining us here. We are really, really honored to have you here. Thank you. Now we are moving on to the penultimate panel discussion for this event. And the panel is on antimicrobial resistance, a global challenge requiring a One Health solution. And for that panel, I would like to request the chair and invite him, Professor Anil Paul, Director, IIPH Hyderabad, to please chair this panel. Dr. Anil Paul, and you know him a lot from the morning and also before for many of you. Professor Anil Paul is a physician, scientist, public health professional working in the field of infectious diseases and women's health for more than 35 years. More recently, he served as a clinical professor and program director for global health at the Oklahoma State University, where he also directed the High Complexity Infectious Diseases Lab, which he established in 2009. He also served as the chair of the IRB, as section editor for the OSM proceedings, and as a member of the One Health Task Force. Dr. Paul directed COVID-19 testing for OSU, for Oklahoma State, and served as the clinical director for the newly established Oklahoma Pandemic Center for Innovation and Excellence. He also served as a technical consultant for the Defense Threat Reduction Agency, where he worked on global pandemic preparedness projects. Recently, he also served as the PI on USDA-funded project to develop a dashboard for surveillance of emerging and re-emerging infectious diseases. He has served as Senior Health Advisor with the US Department of State, as a consultant for US aid projects, and as a reviewer for the NIH. He also serves as a visiting professor at the New Vision University, Georgia, and as a clinical professor emeritus at OSU. I request Professor Anil Paul to please come and chair the session, the panel, and also request him to introduce the other panelists. Thank you. Over to you.
Staying back and participate in a day long festivities. And I think I told many of us, this is just a nice way just to know each other. And I think moving forward, there will be many more occasions to work together. I think this topic of antimicrobial resistance is very close to my heart. I've worked in this field for a number of years. Primarily because antibiotic resistance is a significant global health issue. And it is closely intertwined with One Health. And that's why I think it's very relevant for this particular symposium. The One Health approach is a multi-dimensional approach where we acknowledge the human, animal, and the environment as they are interconnected. And we require a collaborative effort to face this challenge. As we all know, in the previous panel also, it was discussed that the cause of antimicrobial resistance is primarily the overuse or misuse of antimicrobials. One of the issues which I have faced in India recently is antibiotics in India are available over the counter. Whether we like it or not, it is available. When we talk to Government of India, they say, well, we have policies in place. But policy is only good when it is implemented and enforced. I can sit here on my chair and order online any antibiotic I want. And as a formality, I'll get a call from the supplier saying, you have ordered this thing, what's the age of the patient? I'll say whatever I want to say, and they say it's approved. So formality is complete, but it's a problem. So antimicrobial use is not only in animals, we talked about animal as a growth factor, but I think we have policy issues also. I'm glad society is here. I think we have to enforce, because let's be honest, I think Dr. Nandakishore mentioned about this plants carrying extra stuff, but we also have to remember what we carry with ourselves. I sit on a plane at New Delhi airport on a United 83 and fly to New York. 14 hours later, 16 hours later, I'm there. So whatever I'm carrying, I'm giving and distributing in New York. So I think we have to understand that these issues, these infectious diseases or antimicrobial resistance, they don't respect national boundaries or even state boundaries. When we talk to Government of India, they say health is a state subject. What does it mean? That if something is going on in Tamil Nadu, it will not affect Andhra or Telangana. We have to look at it in a holistic picture. So I think that's why I have this passion for global health, and I have been doing this for the last several years. The other issue is infection control. I think we have some poor infection control issues, primarily in hospitals, and I think we have one of the panel members, she will be talking about it. And as I mentioned, global travel, global trade. We know how West Nile came to US. It was because of trade. And initially we thought malaria will not come to US. It is there. But are we prepared for it? So I think there is a lot of issues, but I think global travel and trade are also important to understand the antimicrobial disease. And I think it's my privilege to introduce our panel members. We have Dr. Akhilesh Krishnan from Oklahoma State University. I know Akhilesh for several years, and we have worked together literally day and night during the COVID. He and myself, we were working in the COVID lab. And a lot of times we, at 2 a.m., he would go to Taco Bell to grab something. So Akhilesh and myself, we go very well. On a serious note, Akhilesh is a faculty member at Oklahoma State University, where he specializes in environmental sciences, particularly in soil and water resource management. His research focuses on sustainable agricultural practices, soil health, water quality, and impact of land use changes on ecosystem services. His work is aimed at developing sustainable solutions to address environmental challenges related to agriculture and natural resource management. His research often involves fieldwork and lab studies to examine interaction between soil, water, and plant systems. That's what we call One Health. And he is actively engaged Okay, but right now Akhilesh has a grant on One Health, which he's working on, and I think they are looking at, if I remember correctly, on animal wastewater surveillance, right? Okay. Okay, my memory serves me right. Okay, so that is one of the areas he's working on, and I think it's a real pleasure to welcome a close friend from Oklahoma. The next one is Professor Shalja. We have heard her since morning, and she has been doing a wonderful job, and I think really proud and privileged to work with her for the last few months. She has been with PHFI from 2009, and she is trained as a physician with double masters and PhD from India and masters in medical science from Sweden, from Karolinska. Her PhD in injury epidemiology from London School of Hygiene and Tropical Medicine was through Wellcome Trust Fellowship. Her interests are to explore public health impact of transportation choices, especially on injuries, physical activity, and air pollution. She also works on environment and health disaster management. She is an associate editor of Cochrane Collaboration and is an invited member of the Cochrane Core Editorial Board as an injury expert. She is currently the Dean of Research and Policy Support at IIPH Hyderabad. Thank you, Dr. Shalja, for being here. We also have Dr. Sitsendu. Well, he was literally in hospital this morning, but he preferred to be here with us. And thank you for being here. Sitsendu is also a physician and currently working as associate professor at IIPH Hyderabad. He is passionate about teaching and research. Previously, he served as ICM at National Institute of Epidemiology in Chennai, and also at Apollo Institute of Medical Sciences in Chittoor.
Good evening, all of you. So I'm Krishnaveni. I'm unit head of Star Hospitals. So I'm going to talk about how do we actually manage this whole antibiotic usage and the rational usage of antibiotics. So quickly, it is in two steps. The first part, so first is all the hospitals do understand AMR is a global crisis concern. So all the hospitals are now aware and oriented into understanding and contributing their level for how do we control this whole concept of AMR. So that is well understood by the hospitals. So even the NABH emphasizes and focuses on these kind of standards and objective elements. So even hospitals participating in accreditation programs do not ignore them. So coming to the whole plan or the way it is done in two ways. One is the prophylactic antibiotics. So the organizations, we define what is the prophylactic antibiotic policy. So after we define this, generally these are taken from the antibiograms or the CDC or ICMR guidelines in consonance with the surgeons. After we define, a very important step is to bring the awareness that we have this policy in place. So sometimes there will be some new doctors coming, there are some visiting doctors coming. So it becomes very important for us to bring the awareness among all the stakeholders. So we go ahead and give a copy to each of the surgeon and try to take the signature so we do not miss this communication. So complete information to the surgeons that we have this prophylactic antibiotic policy, and then a display of a copy in all the relevant areas as in operation theaters, the preoperative area, to the nurses, to the technicians. So everybody in the process are kept informed about the policy defined in the organization. Now that being done, a very important step is to monitor. So we do something called audit. So we do a retrospective audit every month of the previous month to see the compliance of all the surgeries which are done and what is the prophylactic antibiotic dose which is given. And of course, we also check something called the timing. So there are some protocols about 60 minutes of antibiotic dosage before the incision, which is more effective and safe for the surgery. So we audit both the time of the administration of this prophylactic antibiotic and see the compliance whether this antibiotic is as per the policy. After we do this, now we have the data of deviations and the compliance percentage. We are almost at 94% compliant. We started with 60% of compliance and now we've moved to 94% compliance, which is a very big thing, which shows that consultants and physicians are also very much aligned to this step. Now, here we have deviations data. It becomes again very important that these deviations are not left alone or just spoken as percentage, but we need action. So the best way we have found, which worked very well, is that you take this data and meet the doctors on one-to-one basis. So we form a small core group with the microbiologist, with the medical administrator, the infection control officer, and myself or any of my colleagues. So we form a core group and then we meet the doctor one-to-one and discuss with them the deviations, the reasons for deviation. Sometimes it's awareness, sometimes it is the documentation gap. For example, a patient would already be on a restricted antibiotic, but when he comes to the surgery during his antibiotic course, naturally he's given that antibiotic. So these kind of reasons we can discuss, and sometimes the microbiologist will have a very good chance to explain why we need to stick to the prophylactic antibiotic. So this actually brings in a lot of coordination and it helps in a lot of compliance to the defined policy. So this will control the misuse of antibiotics for the prophylactic purpose. The next is restricted antibiotics or high-end antibiotics. So each organization has its own name. Predominantly, we all have similar kind of lists which come into this restricted antibiotic list. Now, once we have the list, we need to again have consonance of all the stakeholders, and this needs to be circulated everywhere, and we need to improve the training that this is the restricted antibiotic list of the organization. Now, what do we do with the list? So all the prescriptions which have a restricted antibiotic needs justification. So how do we do this tracking? So we have justification forms in all the nursing stations and all the areas. And when the pharmacy dispenses a restricted antibiotic, they flag in the WhatsApp group which we've created for the monitoring. So the group is for monitoring the rational use of restricted antibiotics. So once the pharmacy issues, they flag it into this group, and the committee members, the core committee members of the group will understand the justification. Now the justification forms have also evolved, and now we have very, very simple forms to capture, which is very easy for the consultants or the physicians to tick and mention the reason. Is it empirical? Is it justified because of a culture report? And if it is empirical, we have a chance to monitor whether they escalate or de-escalate kind of a thing. And this patient will be monitored to see what are the changes which are happening and whether an appropriate de-escalation is being done or not, appropriate duration is being used or not, the outcomes, the monitoring of side effects. All this is done in a very coordinated manner. Now, this small step of a cohorted monitoring helps in a very large extent to control the use of restricted antibiotics in the organization. And all the physicians also are very aligned to this concept and they cooperate with this. So these two things, the prophylactic antibiotic policy and the compliance, restricted antibiotics usage, monitoring and justification and compliance to this policy, this overall brings a lot of safety and control in usage of the antibiotics in the organization. Now, after all this kind of a control programs, do we still have AMR organisms? Yes, we have AMR organisms, and it comes with a lot of cost. So the hospital perspective is that these things, when they occur, it comes in a lot of cost for the patient and for the hospital. So now what do we do when we see a patient with AMR positive organism? We have to isolate the patient. So we isolate. So the patient necessarily will be paying the rent of a single room or an isolation room. And we have to have manpower for the isolation or barrier nursing. So that extra cost of the barrier nurse or a barrier housekeeper, so that we are at least controlling and not allowing the spread of these organisms. So once we have an organism, the focus is on how to control and prevent spread from there on. So this is what happens when we have an AMR. So then comes the root cause. We need to understand whether it is community acquired or is it hospital acquired. And when we do the root cause of understand it, if the root cause is hospital acquired, and the work is more to understand the source and how did this happen, understand and fix the source in a very permanent way, and look into the whole infection control program again, usage of disinfectants, personal hygiene, hand hygiene. So all these steps and causes are analyzed to fix the reason and control thereof. So it takes a lot of man hours, energy and cost in controlling the spread of AMR. So this is the overall thing which happens in the hospitals. Now, do we have challenges? Yes, we have challenges. So the challenges are at times to convince the physicians to de-escalate. The challenge will be to even flex their already pre-planned therapy models. It becomes very challenging. These are all very difficult, but they're not impossible. It is also very challenging to monitor the de-escalation of high-end antibiotics in the outpatient and inpatient setups. Sometimes it does not look feasible at all to do the monitoring because it needs a lot of strategy, it needs manpower to look into those kind of areas and monitor, collect this data and analyze this data. Otherwise, we cannot use it very usefully. So this is how the whole process runs in. And coming to the next part, which I would like to speak, is the importance of collaboration in these scenarios. Now, most of the time, it becomes very difficult for us to understand the susceptibility patterns from the antibiograms which are made in the organization by the microbiologist and their team. Now, when we have a collaboration, if we can all understand the susceptibility patterns across the hospitals, in the same city, the adjacent cities and in the states to learn much better. We can also understand different organisms, how they are evolved, understand is it endogenous, is it community acquired kind of a flora. So this data from different hospitals and advanced labs which does the cultures, this will help. The collaboration with these will really help to understand this data much better. So we can also learn the treatment options. What are the outcomes? Are there any side effects which these patients get by when we use this high-end antibiotics? So here, another thing which I would say, which we learned over a period of time, is when it comes to an AMR or an MDR or a pan-resistant drug. So we have really saved colistin to a very large extent. In colistin, we generally use the polymyxin B. So our polymyxin A is used. Polymyxin A usage till now is 0. So we feel very proud to say that we haven't used any polymyxin A to our infected patients, and we were able to successfully treat them with polymyxin B as of now. So this kind of insights, when the organizations collaborate, they can learn from each other, they can share their data and analyze, and the data will be very insightful to conclude and improve upon from this kind of learnings. Another very important challenge is hand hygiene. Now, there is a lot of convincing data that effective hand hygiene can definitely reduce the hospital-acquired infections. It has been proved at various levels and multiple datas, and when you see the root cause, the breach is hand hygiene. So in this collaboration, the organizations can learn how to implement this hand hygiene programs very effectively. So how do we learn and how do we improve? When we have the data of what is our actual compliance. So how do we audit hand hygiene? Even the tools which we have in hand hygiene, from what I've seen over 10 years, there are very good tools which have evolved, very good techniques to capture the data. But some organizations still have some better techniques. So the sharing of this knowledge on how to audit the hand hygiene and get that correct data so you can actually improve correctly will also help to implement a very good hand hygiene program. And again, that will actually help to prevent hospital-acquired infections. So if you see this, I mean, like if you're listening, it's a very big vicious cycle between the infection control, the hand hygiene, and infection control of hospital-acquired infections, the prevention of hospital-acquired infections, and then the usage of antibiotics. So somewhere we need to break the cycle, we need to break the chain, and for that we have to collaborate. And One Health is an amazing concept. I have actually heard about this a lot in the GSPAC conference. Very, very comprehensive, very intense. And I'm sure when we collaborate and we all learn and implement these kind of insights, we will definitely have a good antimicrobial stewardship programs coming up in the organizations. I will end with this. Thank you so much for giving me this opportunity to talk in this program.
I would request Dr. Akhilesh to give his perspective, because he is in a unique position of working in an animal diagnostic lab, but also dealing with human infections. I think we have seen, at least during my visits to his lab, the animal infections crossing over to humans and human infections crossing over to animals. What has been your experience about those, I would say, interspecies transmission of infections?
Thank you, Dr. Cole, and thank you everyone for this opportunity. So, more than the interspecies transfer, I think can you hear me? Is this going on? One confusion we have on the veterinary side is how effective many antibiotics are, right? On the human side, it is quite easy. You have a patient come in and you know he's a human being and you know what treatment to do. My wife, she is a veterinary practitioner, and especially in the US, she doesn't know what patient is going to come to her. She's come home and said, this is probably the first time I've seen this species. I don't even know what the species is. Right? And you have to treat those animals. Now, treating those animals, the issues are you don't know what the pathogens are, you don't know what the dose is for those animals, and you don't know what the effective antibiotics are. So once you take that into account, the veterinary field becomes so complicated in the sense we do not have MIC values for many antibiotics. And I'm wondering, all the students here know what MIC values are? Have you had a microbiology course? Yeah. So MIC is a minimum inhibitory concentration of an antibiotic. And that is determined in many cases based on what an effective concentration of the antibiotic is that can kill a bacteria. Let's take any infection. In humans, it's been established. In animals, probably it's established only in one species. It might only be established in a dog. So you're going to treat a species of animal that you don't know in some cases, and you might know in some cases with an antibiotic that you don't know what the MIC value is. And now that can contribute to AMR. And that's a huge problem on the veterinary side that we have. We don't know if the dosage we're using is good. And it's a global problem. It's not unique to the US. It's an issue that all of us veterinary clinical diagnosticians or microbiologists are dealing with. And coming to your question on the interspecies jump, at least in the dogs, cattle, the common animals, we know the zoonotic pathogens. And we've seen infections. It's quite common to get anthrax, the skin-borne anthrax. In Oklahoma, we have a condition called tularemia. Someone else, I think Sunil mentioned it. Tularemia is so common in people dealing with rabbits or squirrels, that kind of stuff. But when it comes to these exotic species like a sugar glider, or many people have snakes, what bacteria there? Salmonella is common, we know, in many of those species, but what else is there? And that's where the technology aspect comes into. You start doing metagenomic studies, and you identify, now you have a patient that you don't know what the species is. You do metagenomic studies and you get a bunch of bacteria that you've never heard of. And then the clinician needs to know, are these bacteria pathogenic or not? And they call the microbiologist and ask, what do you think? And we give them an idea of what we think. At least we try to group the bacteria into a family level. And if they belong to, let's say if it's a respiratory pathogen and you find something in the Pasteuracea family, assume that it might be that. So there are unknowns in that case. You don't know how risky it is for them to jump into humans and any other species that it can. So in this case, what people mostly do in the microbiome study is look for bacterial microbiome. It is very rare that people look into other pathogens like viruses and parasites. And the virome in many of these species, we've started doing a little bit of studies in some of these species. The virome is way more exciting than the bacteria. And how much of that viruses can jump into humans, it's again something that we don't know, that we'll have to look into.
Thank you. I think a question I have for you is, where do you think the research between different species, different groups should focus on? Indicate that one challenge which we have, the microbial resistance. So I think, what should be done? I know at a policy level that there has to be a uniform policy, but at a research level, what needs to be done?
Thank you, Dr. Paul. We all know that AMR, basically, the resistance, we have very little information on that. Although there are estimates, in terms of accuracy, we don't know how accurate they are. Because we know that this is just the tip of the iceberg thing that we are talking about. And it's across. I mean, when you look at humans as well as now, if you look at the One Health perspective, in animals, in plants, etc., in livestock, it is anybody's guess, although there are estimates, as I mentioned. So, the thing that we are familiar with at the household level is that some person has felt, has fallen sick, has taken antibiotics for 2 or 3 days, feels better, and then discontinues it. It's very common for us to hear such things. It happens in our own households. That is one thing. The second thing is that when somebody in the household or their friends fall sick, then they call each other and say, hey, I had a similar thing, I had fever too, 3 months back. I have some antibiotics left, here you go, use them. And then the other person is happy because they're cost saving, because some of the antibiotics can be expensive. Again, that other person could take it for 2 or 3 days and then stop. So to answer your question, Dr. Paul, I think we need accurate estimates of, first of all, what is the antibiotic consumption, again in various sectors that we are talking, not just humans. That's one thing. Second, we do not also know how much of it is at the resistance, how much of it is at the community level, and how much is at the hospital level. Again, we have estimates, but in terms of accuracy, we are not sure. That's another area of research. And the third thing is in terms of the resistance or the sensitivity patterns. We have some idea, but again, we do not know how accurate they are. At least for these 3 important things, it will be very good to proceed with more accurate estimates, is what I'm thinking. And the fourth thing in terms of research, again, we should do interdisciplinary, transdisciplinary research and talk to sectors. Otherwise, we'll just be working in our own thing and we do not know what is happening in the next institute. So I think it would be good to start off with these 3 and then see what are the intersections in terms of animal, plant, livestock, human, etc. and to see the whole thing. It's just the Olympic rings that we have to juggle and not just look at our own thing in terms of research also. The same concept for One Health should, the same thinking should go into research for all these sectors. That's what I would say.
Thank you, Dr. Shailaja. And I have a question for our surveillance expert, Sir. What Dr. Shailaja mentioned that we don't have, what should be done to track what antibiotics are being used or what kind of antibiotic resistance is.
Right. Thank you, sir, for the question. I'll give you a short example and my life experience. Usually I like those to answer to your question, sir, of course. I was somewhere in southern part of the country again, and I was involved in a fever surveillance. The main idea was Salmonella species identification to make it for the room easier. We were looking for typhoid cases. It was a community level typhoid surveillance to be specific. And we were looking for kids who are having fever for more than 3 days. And then we also captured, or we were also capturing that whether they are taking antibiotics and how is the antibiotic using pattern. Slowly we realized that there is something, a complex relationship exists in antibiotic usage. So when we went to the house-to-house, went for house-to-house surveys, and then we realized that a child, school-going child, let's say, having not even one whole day fever is also taking antibiotic. Why? They have to go to schools. They cannot miss schools. And therefore, the parents are anxious. They are taking to the doctors. On the other side, doctors, when they are trying to say that no, for 1 or half day or a single episode of fever, you should not take an antibiotic. We should be on something called a conservative management, like paracetamol, like hydration, most of it are by the fever. Then parent stamp the doctor as not a good doctor because they require antibiotic to send the child. Not only that, the child goes to the next doctor. They are not happy, the parents are not happy. They go to the next doctor. The next doctor says that, okay, do some blood test. They're asking for what? Vidal test. Apart from, let's say, the usual routine tests. Vidal test in India obviously will say that, okay, some 1:80 or 1:160, which is very much common, which is you cannot expect 0. They mark it and they say that, see, the other doctor did not treat you well. So we are starting on antibiotic. So antibiotics started. In this complex relationship, what else happens is like the influence of the medical representatives. Or I will take to the, and it is a fact, you take to the industry, the pharmaceutical industries, their ideas and their promotion, how you can use antibiotic more. And therefore, they are pressurized, doctors are often pressurized that use antibiotic because of whatever XYZ reasons. I'm not going into that. Alright, so in this complex relationship, what we tried, coming back to your question, sir, is antibiotic surveillance. One we did is like, yes, understand through this fever surveillance or through even for diarrheal surveillance, also we see that in diarrhea we give antibiotic, again, which is treated with simple ORS. Now, that is one way of solution. We establish, apart from hospital level surveillance, which I am sure that we heard Dr. Krishna Beni, and we know that yes, we can do that at the hospital level. But as Dr. Shailaja said, at the community level, if we come, then these are costly surveillance, of course, but still, yes, we can do that, at least for the targeted populations, like pediatric population, where antibiotic usage is very high. And the second one is, even we can get this information from the pharmacy stores. As you said, over-the-counter drug usage are very common. So that is the second option. The third option is, even we include the pharmaceutical companies that, hey, what is your usage pattern for one single district or a single state? And then we get a holistic idea at a state level or a district level or any administrative level, at what level of antibiotic usage has been done so far. And the other part, antimicrobial resistance or sensitivity pattern, to understand that, I think that is very costly and that is high-end test. So we should include the, let's say, the tertiary care hospitals collectively and not single hospital to understand that what is happening. And similarly, because I am not very sure, I am not a veterinary person, we can, of course, we can include that side as well to understand what level of antibiotic has been used.
I would go to Dr. Akhilesh. On the research side, looking at newer approaches for antibiotic antimicrobial resistance. We have done some studies, we have done some using nanoparticles, nanodiamonds for drug delivery at low doses, and it's been pretty effective. So the latest one is the phage. So what is your thought process on that one? Because I think it's pretty new concept in India, but I know you have been working in that area, and I think that's something which we are also interested in.
I wouldn't say phage is pretty new. It's in the 1950s or 60s, whenever it was. It's new in the sense it's got a revival at this point. People are looking into it with all the AMR issues going on. I think, if I'm not mistaken, in the Eastern European areas and in Russia, they used to do phage treatment long ago, and they used to have well-developed systems where you could make phages on a bespoken, custom-made phages. So instead of using generic phages, if you have an infection, the lab cultures the bacteria, gives it to the phage lab, and they make phages for that. So it's personalized medicine in a way, right? That's quite, to me it's quite interesting. It's something we need to look into. At least phages are natural. It's not something unnatural that we are adding into the human system. Someone mentioned about cricket, and in my mind, bacteria and phages are in a constant game of cricket going on. The phages are throwing bouncers at the bacteria, and the bacteria are trying to figure out. It's like the body line period where the batsmen at that time were trying to clear it out. And once they figure it out, there is resistance in phages also. So once a bacteria figures out a method on how they can get rid of the phage, a new phage comes in. So to me, phages are, it might not be a treatment that we can do on its own, but it can help in reducing the dosages of antibiotics, especially if we use it in combination. That's something we are trying in our lab right now. And especially for multi-drug resistant bacteria, we have developed phages against MRSA, phages against salmonella, multi-drug resistant salmonella, E. coli, enterococcus, all these pseudomonas, the innately multi-drug resistant bacteria, as well as bacteria that have acquired multi-drug resistance. And they are quite effective. The challenge with phages is going to be, phages are also highly specific. So if the bacterial strain changes, it might not be effective. And that's what we are evaluating at this point. We've got around 100 pseudomonas isolates that we've got from otitis externa cases in dogs. And we are trying to see how much of those phages, we've screened for phages against all of them, and now we are trying to do a checkerboard and see, does phage 1 that was isolated for bacteria 1 affect bacteria 2, 3, all the way to the 100 that we have. And if so, that would be, I don't expect it to be, if so, we would like to sequence it and find out what specialties it's got, and see if we can synthesize the phages in the lab, like do some recombinant synthesis and make more of those kinds of phages if we can. The other aspect, other than phages, is antimicrobial peptides is also a concept that's relatively new, but that's also been around for so many years. It's again natural, and we're looking into antimicrobial peptides as well. And definitely what we've found with at least a couple of peptides that we've tested is it significantly reduces the dosage requirement of antibiotics. And we don't know how it's happening, but the thought process is probably it's making holes in the bacterial cell and making it more permeable to the antibiotic. And in addition to doing the peptides, we are also seeing if we can make synthetic molecules that mimic the the physical and chemical properties of a peptide. So if we know that a peptide molecule is effective, we are trying to find out where it acts, and in many cases it's these outer membrane proteins or whatever pumps the bacteria have, right? And the 3D structures of those are known, the protein. And what we are trying to do is using AI and machine learning. Dr. Agarwal is helping with that. They are trying to design, based on known peptides that act on them, design molecules that can mimic those that we can produce in large quantities, and look at effectiveness of those. So those would also help to bridge the gap in new antibiotics coming out. It's not going to be an easy process, but it's something new that we are trying as well. But yeah, in short, to answer your question, I think phages are promising. I hope we can administer them other than topical, intravenous. We'll have to develop whatever methodologies are needed to administer the drug, right? To administer the phages to go into whichever system it has to act on. But it's definitely effective against multi-drug resistant bacteria that we've tested against.
Thank you, Dr. Akhilesh. One thing which we have been working on is developing receptor analogs, particularly for UTI E. coli. That has been pretty effective. I think bacterial colonization leads to infections. So if we are preventing bacteria from colonizing itself, I think there is no need for antibiotics. So that attempt is being made, and we have done some antibiotic receptor analogs. So there are different methods of doing these. Question for Dr. Shailaja is, when I was in medical school, or even practicing in Chennai, our standard used to be cultural sensitivity. That was the first step. I think that is going away. Is that right?
Thank you, Dr. Paul. I'm not an expert in that, but I think that there are newer ways and they're more rapid diagnostic tests for culturing, mainly to see if there is resistance and what the resistant panels are. And from what I know, the time required for getting the test results back, right now it takes a long time, sometimes 72 hours. But what I hear is that that time is going to shrink more and more. And that will be very useful because otherwise people start an antibiotic without knowing the report.
I was mainly referring to the training we used to get is that don't prescribe antibiotics before you get the culture results. I think that is going away. But on the technology side, I think it's very valid. I think there is now companies like Illumina, they have come up with these panels. They can screen for, let's say, 140 different bacteria and viruses and the antibacterial profile. And the results can be obtained within hours, if not days. So I think the technology is moving very fast. The cost is also coming down. It used to be very expensive, and I've been fortunate to working with Illumina. And the cost has come down significantly. They have now different panels, GI panels, UTI panels, respiratory panels. So I think technology is setting. I think very few places now they rely on cultures. Cultures are almost history. And I think COVID, one good thing which came out of it, now everybody knows about RT-PCR, which before COVID not many people knew. But the technology is emerging very fast. We have to keep on.
There's a large differential in certain areas, like in urban settings and in the capital cities and things like that. The technology aspect, it's taken up very well. But if you move to the peri-urban areas and then to the rural areas, we still have that 72-hour culture report that people await. So we see that it will be good to have that gap reduced, and moving forward, I think that is one of the things that will happen, because it has to catch up sooner or later. And I think the newer technologies will help in seeing that happens. But right now, I still see that there is some differential, much more in some areas and less in the urban centers. Yeah. But you're right, it has a huge potential.
Thank you. I have an observation. Primarily from my experience in the US, antibiotics in the poultry, particularly, which is what we brought up. I lived in Tulsa, which was very close to Arkansas, where rice and chicken people are famous. And they used to give antibiotics in 64-gallon drums. Basically, put it in the feed and just serve. So I think that's a huge issue. It's not only here, but it's global. The other issue is, I think there is no monitoring. One shocking thing which I found was that bananas come from different South American countries, at least the US market. They were spraying them with antibiotics. I used to ask them why. They say it increases shelf life, but even if it increases by 1 day, it's billions of dollars revenue. So everybody has different motivation. So I think there are different battles we have to fight, but these are real issues. We go to grocery stores, at least I'm not in years. Produce, they have the sprays. Now they've started adding antimicrobials into those sprays. So I think it is widespread. And unfortunately, some of the large chains in India are coffee. So that is, I think those are the challenges. I think for you, I think I'll stay with the surveillance. What should we do?
Big question. I mean, it apparently looks like the shortest question, but this is the biggest one. One word, short answer, integrate. I think we are coming almost to an end of this symposium, and here is the opportunity. I feel that we have representatives from everywhere in this One Health Road, what we are calling, especially that representatives from all the institutions here. I'll just take an example of to answer that question. One example, poultry antibiotic use. Finally, it is going where? Through the excreta, going to the environment, mixing with soil, mixing with water, and I think all the institutes lies here works on those aspects. Human health, poultry health, water, soil, everything is there, veterinary, everything is there. We have to understand how we can integrate. We have rural health stakeholder as well. I mean, how we can integrate effectively with smallest thing possible. For example, if we say that, okay, let's say the morning the discussion started, and I was not here and I heard afterwards, that healthy village concept. And healthy village concept, take a village, can we jointly draft our concepts, put together, share with each other, come to a consensus that this is what we can do with these objectives, simplest possible objective. I'm not saying too high-fi. Let's say AMR and all, yes, there are many teams who are working on this. There's no going to that. The practical aspects, what we can identify, the problems, the challenges, let's see how practically we can solve it together. So that's my answer to your question.
Thank you, Dr. Sri. I think with that, like with this, that there should be integrated approaches and strategies. I think one of them is surveillance and monitoring. It will be very important. Particularly antibiotic use and resistance patterns in humans as well as animals. I think that will be something important. Second will be education and awareness for everybody. I think it's for whether it's healthcare professionals, whether it's veterinarians, farmers, and general public also. I think that awareness has to be created. Education, I think it's, as a public health officials, I think it's our responsibility to do that. The third one is on the policy side. Policies have to be there, but policies have to be enforced and implemented. I think without that, we cannot move forward. I think there has to be support on that side also. And lastly, and also more importantly, I think we have to also invest in research and development. Look for newer approaches to deal with infection in the children. I think all those things will be very important. I think I will say that these are the 4 pillars which we should work on. And that's all. I will ask the audience if they have any questions for the panel.
Sir, a very nice discussion actually. So I am Dr. Sujata Singh from PVNR University. So I am a veterinarian, so associate professor. Sir, just I want to ask Akhilesh sir. So what is the research is going on in AMR sir, in Oklahoma State University? What the research you are doing presently against the AMR? Is there any particular research is going on?
So I work in a diagnostic lab, the Oklahoma Animal Disease Diagnostic Lab, and we test samples, the clinical samples that come and isolate the bacteria, perform MICs, and look for resistant bacteria. So as part of that network, we also work with the National Animal Health Laboratory Network, which is part of the USDA, and we also work with the FDA veterinary component. So with both of these entities, we have projects going on where we do whole genome sequencing and try to identify clones and genes about AMR, basically genes that cause AMR. So that is one aspect that is going on. We are trying to identify if there are any specific traits or anything going on within the country as a whole. It's not just Oklahoma, the whole state, 50 states, all states that have a diagnostic lab participate in that, and that's a huge endeavor that's going on right now at the national level that we are contributing. Then at OSU we have grants, research grants, research projects on which we are working on, and those mainly involve development of the phage that I mentioned. So we're screening for phages, trying to look at alternatives for antibiotics. Are there any alternatives that we can use for antibiotics? We've looked at some urban products as well, some plant-derived things, but the main focus is on trying to develop phages and also developing peptides, designing peptides. Basically, we are trying to use not use peptides that are already in nature. What we are trying to do is see if we can design peptides against known targets in bacteria. So identify what would be the weak points in bacteria and try to develop peptides against them and look at efficiency of those, ultimately with the hope that we can use them as a drug. That's a hope that we have. But yeah, those are the main projects going on.
One thing that bacteriophages are very specific in their action. So it will be very detrimental if you are producing and acting against the different bacteria. What I feel, it is not that much safe to use in a common strategy.
Thought that we've also had, bacteriophages are definitely very specific, but we've also isolated some phages that have broad activity. And if we even use the phages, the goal is not to use a single phage. We would be using a cocktail of phages and try to use that. So, and in addition to using the phages, we would also try and isolate the actual pathogen and develop. Screening for phages is not a very complicated procedure. It's stuff that's been done for several decades that people have developed and optimized the procedure. So isolating a phage would not be a complicated thing, and in that sense it would be advantageous because you're doing a patient-specific treatment at that point.
Thank you so much, Dr. Akhilesh. With that, we'll end this session, and if there are any questions during the break, we can probably take questions.
and the panelists, including me, for that wonderful session, for that very nice panel. And thank you so much to Krishnaveni Garu, who was patiently waiting for us online all this time because the sessions got pushed. And I thank you a lot, Krishnaveni Garu, if you're still there online. Thank you for joining us. We will meet up sometime in person. Thank you. Okay, that brings us to the last panel for today. It is on community engagement in One Health initiatives. And I would like to invite our next chair, Professor Acharyalu, Dean, School of Management, University of Hyderabad. And I request Nirupama, please, Dr. Nirupama, to present, sir, with a plant. I'll do the introduction in the meantime. Dr. Acharyalu is the Professor of Operations and Supply Chain Management and Coordinator for the MBA program on Healthcare and Hospital Management at the School of Management Studies, University of Hyderabad. With over 18 years of teaching experience and 10 years in international conferences across the US, Australia, Singapore, and other countries, and serving as a visiting faculty at the Asian Institute of Technology, Bangkok. He has supervised 7 PhD scholars and is currently guiding 4 more in the fields of operations and supply chain. As a Vice President of the Indian Subcontinent Decision Science Institute, he plays an active role in advancing decision sciences in India. In 2017, he was awarded the AIMS ICFI Best Teacher Award, recognizing his contributions to management education. I invite you, sir, to please invite the panelists. Over to you. Thank you.
Thank you, Professor Sarah, Madam. The last session, not this session, least one. I'm very happy to associate with this last panel discussion on community engagement in One Health initiatives, which is very important in the present day context. Of course, so many technical sessions happened so far, but this session is totally different, as I think. Most of in general and mostly management oriented. So anybody can participate in discussions in this topic. Today we have eminent speakers for the session. I request, I invite the session speakers into the dais. Dr. Susmita Sundar, Dr. K. Shiyasarki, Dr. Suchindra Pujari, specialist with a deeply held passion and curiosity for entrepreneurship, for entrepreneurial mindset, passion for entrepreneurship in the life sciences sector, and also the entrepreneurial life mindset has begun while doing a PhD in biomedical engineering and also a course in management of technology from National University of Singapore. She is also very much involved in startups through programs such as Singapore, Stanford, Biodesign Technology Launch. Her professional journey began in entrepreneurial education, training in ISB's Center for Innovation and Entrepreneurship.
So without further ado, I would present my thoughts as a story. As a mother of an 8-year-old, I'm so used to stories, so I thought I'll do that. And since this being the last session, I hope not to put you all to sleep. So this story is A, B, C, D, E, F. So the 3 letters of my first story are B, C, D. B for bat, C for cow,
and D for dog. And the letter that connects the bat, cow and dog is animal. So A, B, C, D is covered, okay? So the first story on bat, when COVID hit, the carrier was bat. It was an unknown attack. Nobody knew what it was all about. But there was a strong intent from the top, that is from the government, and resources were ramped up for usage of vaccine research, vaccine production. Resources were ramped up for diagnostic kits. So RICH is part of Office of PSA, Principal Scientific Advisor to Government of India, under their megacity cluster projects. So there are 8 megacity clusters in Hyderabad. RICH is the Hyderabad Science and Technology Cluster. So during COVID time, RICH was part of Hyderabad's Reagents Consortium, which was part of the National Reagents Consortium for making India indigenous for rapid diagnostic tests. So there is one company called Huel Life Sciences, not very far away in the Medical Devices Park in Sultanpur, quite close by. And this company was the one among those companies which were instrumental in making RT-PCR test kits. The world didn't know how to diagnose COVID. Huel Life Sciences, they manufactured the genomic probes, reagents for the RT-PCR test kits. And it was not an individual effort. That was one startup, but they needed reagents, which was collected from the MSMEs around. It needed to be validated. So the research institute, CCMB, played a huge role in that. CCMB was part of this entire consortium, and it was funded by FIND. So FIND is an institute which was part of the funding. So there was a clear intent from the top government in a reactive mode, but in a mission mode. So that's my first encounter of unknown attack. My second encounter, which is my second story, is cow. Cow, one of my friends in my neighborhood, as a peer, I got to know that they had an unknown disease, went to pillar and post through various hospitals. There was no diagnosis done, spent multiple hours trying to understand what was the cause, spent huge amounts of money. Insurance was not covered because the cause was not known. It was an outpatient treatment so far. Finally, after 4 months of cruel trouble, they found out it was brucellosis, which is a zoonotic disease transferring from cattle. It was not an unknown attack, but it was a rarely known attack. Doctors were not aware. Doctors were not trained to identify zoonotic diseases. Diagnosis was there, but it was not prescribed. So that was my second encounter with intersection between animal and human health. The third story is dog, and this was something which was very close to me. Me and my friend, after almost 15 years, I love traveling, so I used to backpack when I was studying in my master's in Germany. We used to go to different cities, just go walk along the streets, explore the place. Early this year, me and my friend got such an opportunity in India. We went to a place called Jodhpur, not a small village, not a town, it's a touristic place. And Jodhpur is known as a blue city. The buildings, there is one particular track where the buildings are blue in color. It's highly beautiful. What we noticed there, 8 o'clock in the morning, there were dogs chasing and my friend got bitten by it. And this is not a travel, a tourism, a pleasure trip turned out to be a learning for us. The community around knew that dogs over there are prone to biting them. They are very aware of that situation. They are known to rabies. And the recommendation at the time of attack was put turmeric and chili powder. But we didn't panic. We said, no, that's not the solution. Let's go to the hospital. Went to the hospital. We noticed that it was a very rampant issue there. On an average, every day, the hospital workers see around 250 cases on rabies. I mean, dog bites. In our own, in front of our own eyes, we saw people teared very rampantly by dogs. And the reason being, dogs are not being fed or they don't have access to food, so now they are attacking humans for food. And it's not a village. Jodhpur is really a good place. It's a touristic place. So animals and humans coexisting poses a One Health risk. And segueing to my final story, the F story of fish is environment. I come from a place called Kanyakumari, the bottommost part of India. And fish is our common diet. Kanyakumari, even the poorest family will eat fish for 10 rupees. And it's known that now increasingly cancer cases are detected in the population in Kanyakumari. And the reason being the diet of fish. How do fish bring in carcinogenic agents? Nobody knows. So environment is posing a risk in human health. So there is a need for One Health approach, and that's where I would want to present what Office of PSA, Principal Scientific Advisor, is doing as a national One Health mission. I wouldn't say everything is set in place. It's a mission in progress, and that's where I would end with 2 P's, and that's a call for PPP. It's a partnership for not just public and private, it's a partnership for person to person. If we want a world where we all can live in safe, I think the both partnership of vertical, which is public and private, and the partnership between people to people is necessary. I would urge you, if I have tickled your brain, look through the National One Health Mission, which Office of PSA is putting forth. It's at the national level, as Prof. Paul mentioned, health is a state subject. It needs a collaboration at the state level too. We are happy to take that forefront. RICH is a collaborative entity. My call is, it's a wonderful platform and we wish to partake. We work with research institutes, academic institutes, industries, startups and government. So we would like to see how we can bring in the various stakeholders together. Thank you for this opportunity.
A nice introduction of ABCD of concept and also the pandemic experience. So due to pandemic experience only, the One Health initiatives are coming up. And as you see, most of the dogs are coming up to the roads because of social distance. And also lockdown, so people are living in homes. So the animals are coming up, they are free. And suddenly lockdown is off, then finally people are coming out and dogs are staying. So that's why the One Health initiatives have really created a greater awareness after pandemic. So madam, you have given one concept that people to people or person to person.
People to people, community should come together.
Yeah, we look at the community, role of community engagement. So from the person to person perspective, how do we empower? That should be community empowerment. So how do we, what steps could be taken for the community empowerment for person to person interaction or person to person responsibility?
Thank you for bringing that out. I've seen 2 models work in the community. Awareness to that, I think the first key is being a citizen who can understand what is around you for your benefit. I think that's the key to begin with, which I think in schools and colleges we should empower. Increasingly for cyber security as well, there are portals to report. For your personal safety, for animal food safety, there are portals, consumer portals where you can raise consumer awareness. That's one. But second one, as some of you have already highlighted, social media channels. So a lot of them are engaging on the social media, and now there are tools which government is also using to see which is the trending post, which is where most of them are making noise about, and that needs to be addressed, that in terms of civil infrastructure or anything. That's the from the community and to be made heard to the government. But likewise, I feel education and awareness is the key. We need to be aware citizens, socially aware citizens of India.
Thank you, madam. So creating awareness is also key, and also digital technology tools. How do you adopt digital technology tools, connecting the rural and urban population, and using social media platforms. These are all very critical for creating awareness and also bringing some kind of consciousness in the individuals to save the society, to save the planet, and so on and so forth. Now I request Dr. Suchitra Pujari madam to what are the practices, one of the practices that are being there in NRI.
Thank you, sir, and I thank Director IIPH and his team for having me here. Great opportunity to share NIDBR initiatives. So, just to tell you, National Institute of Rural Development and Panchayati Raj is a think tank of Ministry of Rural Development, Government of India, and we do capacity building and training programs for the RD officials at the state and the district level, as well as for the line ministries, Panchayati Raj functionaries also, department also, as well as other line ministries on RD schemes and other schemes across the ministries relevant for the rural, in the rural context. So, great insights shared by the panelists through the day. And building on the discussions, I just wanted to extend the conversation to understand the key role that community-based organizations can play in mainstreaming One Health initiatives. So, community-based organizations, like we work very closely with the Panchayati Raj institutions, with the self-help groups in the rural context to take these initiatives ahead. NIRDPR has been two initiatives that I'm going to talk about. Is one is, as DG sir was mentioning in the morning today, about the localizing the sustainable development goals. So there are 17 SDGs, and Ministry of Panchayati Raj has initiated this entire thing about localizing the SDG goals at the grassroots level. So aggregating the 17 goals into 9 themes. And one of the theme is Healthy Village. Theme 2 is on Healthy Village, which has about 26 indicators listed, and they have been taken from with the help of the Ministry of Health and Family Welfare data. So 26 indicators, and we are now training the Panchayati Raj functionaries, the master trainers who would go down and again train the Panchayati Raj people down below on the different, on these indicators, on the listed health indicators, and how to improve these indicators at in the communities. So that is one initiative that has been taken. So that is a very good platform where we can actually integrate One Health initiatives also. The second thing is, other than the LSTG goals, we also have the GPDP, Gram Panchayat Development Plan, which is the Ministry of Panchayati Raj is it is a framework basically, which is where every Gram Panchayat has to develop a plan for its Panchayat, identifying the challenges, the priorities, the targets they have to set within a year, what they can achieve. So as sir was mentioning in the morning today, there are a number of health indicators. But like if we say reduce the IMR, they do not know what exactly to do to bring it down. So that is where we need the intervention to tell them how to go step by step to kind of in the long run bring it down to the reduce the IMR in the community. So likewise, there are other health indicators as well. So it's a mix of indicators both communicable indicators for communicable diseases as well as non-communicable diseases. We have started this training very recently. In the last 3 years, these trainings have been going on at the state level, at the district level as well. And we have also collaborated with National Health System Resource Center for creating national level trainers who would go down and train the Panchayati Raj functionaries on health, especially because you all may be knowing the 15th Finance Commission grants. They had a certain, I think 70 crore or something, which was granted to the Panchayati Raj functionaries for the first time to upgrade the health centers, to upgrade the sub-centers into health and wellness centers. So, but then it was realized Panchayati Raj people do not have any idea about the so-called health domain. Even if you ask them in the communities, they just say you call the ASHA, they will tell you. You talk to the A&M, they'll tell you. So they were least, involved in this. And I think it is very important to involve the Panchayati Raj functionaries because they are the grassroots leaders there. And they would spearhead, if they spearhead the entire thing in the community, it somehow falls into place. And because they are part of the village health, sanitation and nutrition committees, the sarpanchs are the chairpersons of those committees, where these One Health initiatives can be, the interventions can happen there. They are part of the RK Rogi Kalyan Samiti, they are part of the Jan Arogya Samiti, so at the district level, at the block level, so they are involved there. But the thing is, these committees are not very active and not very functional. And these are the places, I think, where we can mainstream this One Health initiatives can be integrated. The other place, the platform where we can do it is through the SHGs, self-help groups, women who are working. They have a huge network in the rural India. There are about more than 85 lakhs SHGs in the country today, and they are doing brilliant work when it comes to, of course, they were formulated way back in 1970s for livelihood promotion and things like that. But now the government is also looking forward to involving the SHGs in disseminating the health messages in the communities. And because they are very closely tied to the community, the trust factor is there. They know every household in the community, and they have also done excellent work. Jivika, for instance, if you may know, Jivika is an SHG group in Bihar, under Bihar Livelihood Promotion Society, and they've done excellent job in during COVID time, as well as in disseminating other health messages in with regards to maternal and child health also. So there are research evidences which shows that not many research has been done, but there have been research done by BMGF and others also. So SHG can be a very good platform through which the community can be engaged to where we can spread these messages, One Health messages. So the question is, how best do we integrate? Can we integrate One Health initiatives through these platforms to take it forward? Thank you. So that is all.
Thank you, madam, for the nice insights. NIRD, we are having a lot of community engagement practices. So in these practices, you have mentioned about One Health Village. Healthy village. So creating a healthy village. So in creating a healthy village, who are the major stakeholders to bring in successful community engagement? Or you can say that, how do you define a successful community engagement program?
Sir, as I said, the healthy village concept is being led essentially by the Panchayati Raj leaders at the grassroots level. Of course, district panchayats are also involved, block panchayats are also involved, but the sarpanch and his entire team, they are leading it forward. And we, as I forgot to mention this, we reach the community through SIRBs. We have State Institute of Rural Development in all the states, who we train They then further train the extension training centers. We have 90 extension training centers across the country, and through them we reach the community. So I think Panchayati Raj functionaries play an extremely important role in this regard, because they are the bridge between the community and the government also. And they facilitate the community meetings. And there are all groups who are supposed to be part of these meetings, not just the SHG groups are part of these meetings. The marginalized sections from all sections of the population have to be part of these meetings. They have to take their consent, and then they go ahead with implementing the policies in their gram panchayats. So yeah, they are the major stakeholders. Along with them, SHG groups are there. Other than them, there are other community structures, like we have the farmers group, we have the youth groups, the women, the elderly groups, through whom also these initiatives can be taken forward for engaging the community in the school health education, for instance. Children can be, this can be introduced in the school health curriculum also, and where children, they are told about these messages, because they bring back these messages home as well. So that is one thing. Community mentors is something which somebody was mentioning in the morning today. So we, while in our aspirational blocks program, there was a lot of discussion on this. The community advocates, how they can work closely with the community, and there's a lot of acceptance, because these are people from the community. So there is a lot of acceptance by the community, men, women and everyone, as to what they have to say with regards to to promote certain health messages, or to prevent, to promote good health. So that's something which we can also look forward to, and that is what we are also trying to do. Those who are volunteering to work for us on this, we are training them as well through the representatives who are already trained by us, and they take it forward to the community.
Thank you. Now I request Dr. K.C. Hassareddy to throw some light on community engagement practice in education institutes.
Thank you, Professor. Am I audible through mic? So thank you, Dr. Kaul, for making me part of this conversation, and very good evening to everyone. Advantage of being last speaker is I could accumulate so many thoughts and I can just summarize. Since morning I have been listening to so many healthcare professionals and veterinary doctors. So I am a management professor specializing in finance. For first decade of my finance courses, I've been, of course, we closely work with corporates, and I've been championing this idea of wealth maximization, that is enhancing economic value. And then these Millennium Goals and Sustainable Development Goals concept has come up, and slowly corporates started moving from creating economic value to creating social value and then ecological value. And at IMT Hyderabad, we have Center for Sustainability and CSR. That's where we try to champion the idea of creating social value and ecological value along with the economic value. We call this as triple bottom line, or PPP, not public-private partnership, but people, profit people and planet. So I'll share two initiatives, one at our own institute and one which we have been championing with the HR fraternity and corporates. So my campus, like this IIPH campus, was started way back in 2011. It was a greenfield campus, literally in the middle of a village, where we displaced, I think, so many species of animals, including snakes and so on. And 800 of us are staying there. It's a fully residential campus representing from 25 different states. And since 2011, very consciously, we took a call that if we are championing sustainability, we should first practice and then educate or create awareness to the stakeholders. So in our campus, it's a 30-acre campus, 90% is green carpet, having more than 10,000 plus plants and trees, and student community around 720 and 80 faculty and staff. The residents the hosteliers usually come and share with us, I mean, there are so many snakes in campus. Then we say it is we who occupied their space, and we need to learn how to coexist. And there are so many, all kinds of species are there, especially dogs. I don't know whether you have experienced dogs in campuses is a huge menace, but how we came out, there are some faculty and students who have adopted those dogs, and so we started coexisting. So first, last 13 years we have been practicing or learned how to coexist along with plants and the flora and fauna in the campus and the people around. And that's how the Center for Sustainability and CSR, we have a goal of being net zero by 2035, and being net zero means we will have to have sustainable practices and coexisting with the plants around and animals around is one such practice which I would like to share. And second one, since morning I have been listening to all these speakers talking about, I met so many physicians, physical health. I don't know whether there is an acronym called VUCA, volatile, uncertain, complex and ambiguous word. From VUCA word, we are moving to BANI word. What is BANI? Brittle, ambiguous, non-linear, incomprehensible. The difference between these two is the leadership strategies for or leading in a BANI world requires swift adaptability, whereas leading in VUCA world requires adaptability. Leading in BANI world requires somebody to be resilient and psychologically having psychological well-being. So that's where we engage with two communities, one HR professionals, the other one CFOs, finance professionals. We did focus group discussions with 80 HR leaders in 5 different cities, trying to understand, especially this phenomena came post-COVID. During COVID, all corporates were compelled to do from work from home and related so many psychological issues, and the HR professionals were at the forefront taking care of their well-being and ignoring their personal well-being. So that's when who will take care of the caregivers? So we made a small study and found that the role what were the reasons for the well-being of the HR professionals. One factor which was influencing their well-being is role expectations that HR professionals can take stress, emotional burden, workload, lack of recognition, that everyone takes HR professionals for granted. Your basic job is to take care of me. Okay, so, and then the study is ongoing, we'll come with a final report. And the second community with whom we engaged is CFOs. CFOs are the one who will take care of the financial health of the companies, and they were terribly ignoring their physical health or also emotional health. So through CI CFO learning sessions, we've started engaging with doctors, oncologists, gastroenterologists and cardiologists, and first create awareness. So where our institute is playing a role, the Center for Sustainability and CSR is creating awareness towards one, all 3 of us can coexist, plants, animals and people, and then focusing on emotional well-being. Thank you, Professor.
Thank you, CSR, for nice information. We also take up a lot of initiatives in the University of Hyderabad campus, 2,300 acres campus, the green campus. So in spite of that, how do we cope up with the existing issues in terms of creating some kind of ecosystem? So we have committees, student committees and faculty committees to look after the waste management issues and also issues related to the health issues related to students, and health centers also doing a lot of work, health initiatives. So the University of Hyderabad, if you look at, we always try to encourage students to engage in the communities, and we promote them to the different social activities and community outreach programs, and also we also involved in the social responsibility programs. Recently, I think our students went to the Grace Cancer Run, 10K run. So we encourage more.